Good afternoon, all. I welcome you all to this KCIAPM slide seminar being conducted for the month of September. We had to slightly postpone it because of the issues that we had with the quality of the slides. And so we are doing it today. This is for the month of September, and it's being organized by Kasturba Medical College, Manipal. Let's begin the proceedings, and to do that, I welcome Dr. Sushma Belurkar from KMC Manipal to carry forward the proceedings and deliver the introductory remarks. Dr. Sushma, ma'am, over to you.
Thank you, Dr. Aditya. First of all, I would like to thank KCIAPM and Dr. Aditya for giving this opportunity to present the KCIAPM slide seminar this month. So without wasting any further time, we will start with the slide seminar. The first case is Spotter 1, which will be presented by Hassan Institute of Medical Sciences. It's Dr. Gayatri, I think. Dr. Gayatri, have you joined?
Yes, ma'am.
Can you please put on your video on once you start presenting, and please share your PPT. Dr. Kantilata Pai, Professor of Pathology from KMC, will be discussing the Spotter 1 and the long case 1. So we start with Spotter 1. Over to you, Dr. Gayatri.
Dr. Gayatri, please share your screen. Dr. Gayatri Jagdish, please unmute, share your screen, start your video as well.
Hello, sir.
Please share your screen.
Okay, sir.
Please click on share screen, select entire screen. Dr. Gayatri.
Sir, this share options.
Please click on share screen. There is an select entire screen option. Then tap on the screen. When you select entire screen, there is a window that.
Yes, sir. Entire screen I have clicked, sir.
No, we are not able to see anything. Please do it again. Click on share screen.
Share
Select
screen,
an entire screen option.
Entire screen, okay, sir.
And then click. There is a window that appears. You have to click on that and then tap the share button.
Okay, sir. Share. Okay.
So open your PowerPoint and now share the window. Slideshow mode. Go ahead.
Sir, can I start?
Go ahead.
Hello, sir. Okay, thank you, sir. Good morning to all. I am Dr. Gayatri Banerjee from Pathology Department from Hassan Institute of Medical Science. I was allotted as spotter number 1. The history given was a 46-year-old female with hysterectomy done for the fibroid, and one slide was provided. This was a slide we have received, and here we can see that on the first slide that there is a dense hypercellular area, and beneath that there is a hypocellular area. There is a pale area which appears to be hypocellular, and this appears to be a dense hypercellular area. And coming to the borders, we can see that the margin of the borders of this hypercellular area appears to be irregular, and it appears to be infiltrating. So first we will focus into this hypercellular area. So on focusing on 10x view of the hypercellular area, we can see this. There are many spindle-shaped cells which are arranged in interlacing fascicles, and there are all these cells are showing some hyperchromatic nuclei, and they are arranged in fascicles, and there is in between mitotic figures we can see. So I'm going to again some hyperware to explain the cells, each cell morphology. So these are the individual cells. The individual cell appears to be having hyperchromatic nuclei showing features of pleomorphism with a coarse chromatin, and also there is a scant cytoplasm, eosinophilic cytoplasm, and they are having an irregular nuclear membrane. And in between, we can also make out there are many mitotic figures. So this is another slide of this, another view of the same, showing the same pleomorphic nuclei. All these pleomorphic cells having hyperchromatic nuclei and a coarse chromatin. And here we can appreciate many number of mitotic figures. This is also another slide. Here also we can appreciate these atypical mitotic figures here, and atypical mitotic figures we can appreciate, and the cells are appearing to be having pleomorphic hyperchromatic nuclei. And on other area, we have also identified there is an area of necrosis with some inflammatory cell infiltrate predominantly by neutrophils. These were the atypical mitotic figures we have noticed from the slides. Some of them atypical mitotic figures. There were many actually, around 3 to 4 where we can make out in one field. So this was the hypercellular area, dense area, and this nearby to that we can see a pale area. And this area, it appears to be a background of leiomyoma, which is showing the interlacing smooth muscle bundles. And beneath to the, nearby to that, we can see the secondary degeneration, probably a hyaline or a mixer degeneration. So these were the enlarged view of this smooth muscle cells. These interlacing fascicles of smooth muscle fibers can be appreciated, showing leiomyoma features. These were the degenerative changes we have noticed, probably a hyaline or a mixed degeneration. So coming to the microscopic findings, the tumor appears to be highly cellular with irregular borders. Spindle-shaped cells were noticed, showing moderate nuclear atypia with pleomorphism, hyperchromatic nucleus, coarse chromatin, irregular nuclear membrane with a eosinophilic cytoplasm. And there was increased mitotic figures. Actually, on counting 10 high power field, there are around 15 to 16 mitotic figures we can appreciate. And also, atypical mitotic figures were noticed. Areas of necrosis were found. And on the background, we can see leiomyoma with short intersecting smooth muscle bundles and fibromuscular stroma. Area of degenerative changes were noticed, that is myxoid and hyaline change. So based on these findings, I have put my differential diagnosis as leiomyosarcoma, mitotically active leiomyoma, leiomyoma with bizarre nuclei, and smooth muscle tumors of uncertain malignant potential. So we can differentiate each of these. First, on leiomyosarcoma, coming to the gross findings, leiomyosarcoma will appear as a soft, fleshy mass with the cut surface showing necrosis and hemorrhage. And all the other three, that is mitotically active leiomyoma, leiomyoma with bizarre nuclei, and smooth muscle tumor of uncertain malignant potential will appear similar to that of a leiomyoma. And on microscopy, nuclear atypia will be shown by leiomyosarcoma and stem, and mitotically active leiomyoma and leiomyoma with bizarre nuclei, there will not be any atypia. And more than 10 mitosis per 10 hyper field is noticed in leiomyosarcoma, and mitotically active leiomyoma is showing around 6 to 14 mitosis per 10 hyper field. Leiomyoma with bizarre nuclei will show less than 5 mitosis per 10 hyper field, and smooth muscle tumor of uncertain malignant potential will show less than 4 mitosis per 10 hyper field. On also atypical mitotic figures, these are peculiar for this leiomyosarcoma, and all the other three are showing absent atypical mitotic figures. And necrosis will be present in leiomyosarcoma, and mitotically active leiomyoma and leiomyoma with visceral nuclei will be having an absent necrosis, and usually stem will be also having an absent necrosis. So considering all these, our probable diagnosis is leiomyosarcoma, which is an uncommon malignant neoplasm seen around a mean age of 50 years, and it is a malignant tumor of myometrial smooth muscles. It appears as, in microscopically, we can see it as hypercellular tumor with features of nuclear atypia, pleomorphism, mitotically active tumor, and features of necrosis. So this is a gross appearance, how leiomyosarcoma will appear, resulting in a large intramural or submucous mass. It will present like a intramural or a submucous mass with areas of hemorrhage or necrosis we can appreciate. And microscopically, we can see hypercellularity with pleomorphic nuclei and also atypical mitosis and areas of necrosis. Coming to the immunohistochemical features, smooth muscle actin, desmin, and calponin will be positive. Estrogen and progesterone receptors will be positive. Keratin and epithelial membrane antigen will be positive, and there will be overexpression of P53. Thank you.
Thank you, Dr. Gayatri. Now I invite Dr. Kantilata Pai Madam to please discuss the case.
Thank you, ma'am.
Sharing the screen.
Uh, Gayatri, you can stop sharing the screen.
Okay, ma'am.
Is my screen visible?
Yes, ma'am. You have to
Just
open your
you can
PPT.
open the PowerPoint and start sharing. Yes.
Outset, greetings from KMC Manipal. In thank you to KCI, Dr. Aditya for this. Hello? Hello? Is it
Yes,
fine?
ma'am. You're visible, ma'am. You're audible, ma'am.
Okay.
Go ahead, man. Go ahead.
Yeah. So, about the first case, it has been discussed well. It's a pretty straightforward. However, a leiomyoma showing vocally it shows a typical leiomyoma with hyalinization or degenerative changes, showing areas of diffuse atypia, mitosis, tumor necrosis, with features of leiomyoma sarcoma, that is a leiomyoma showing a malignant transformation, is extremely rare. It's very rare, less than 1%, because most often a leiomyoma sarcoma arises de novo, not from a pre-existing leiomyoma. So that's the reason when you have a fibroid, this case came to us for as a fibroid, hysterectomy for fibroid. And when it was it was sampled extensively, we found this focal area which showed on cross examination. Normally, the fibroid has a very firm and white appearance. So, whenever you have some areas which look different, which look softer, which may look a bit yellow, so always sample those areas, if any fibril areas, because those areas might be harboring a sarcomatous. So that's the message I want to give from this case. Otherwise, it's quite straightforward. It has all the features of a leiomyosarcoma. So leiomyosarcoma are of three types. The most common being the spindled or the conventional one, which we saw. Sometimes rarely you can have a myxoid or epithelioid type of leiomyosarcoma. And the criteria for leiomyosarcoma is a Stanford criteria, given way back in 1994, still holds good, which is it should have at least two of these three features. Point to note here is in the area of the tumor, there should be diffuse atypia, either or moderate to severe. This diffuse point is very important because you, in areas of tumor necrosis or degeneration, you can have degenerative atypia. So that can sometimes be mistaken for a sarcoma. So here you should have diffuse atypia in the sarcomatous areas. Mitotic activity should be more than 10 equal or more than 10 per time hyperfield and tumor cell necrosis. Again, this necrosis is very important. It is a tumor necrosis, a cognitive type of tumor necrosis. So what do we mean by that? However, the criteria for epithelioid and myxoid variant of leiomyosarcoma is a little different. The mitosis is equal to or more than 4 mitosis for epithelioid, and myxoid leiomyosarcoma is just 2 mitosis per 10 hyperfield. So these three criteria, that is atypia, mitosis, and tumor necrosis, should be there to make a diagnosis of leiomyosarcoma. Now, what is this cognitive tumor cell necrosis? So this is different from the ischemic necrosis or the hyaline necrosis that we often see in benign gliomas. So how is it different? Here you see that there's an abrupt transition of viable tumor areas with an area of necrosis without an intervening areas. When there is ischemia, it develops slowly. The tumor outgrows its blood supply, so it slowly shows ischemic necrosis. So you will feel like granulation or fibrosis or hyalinization around the necrotic areas. So that's ischemic or like necrosis. So that's not regarded as a criteria for leiomyosarcoma. It's a cognitive tumor cell necrosis, which you can see in our case. There are hypercellular areas of tumor abruptly intervening with areas of tumor necrosis. Here again, you can see areas of necrosis without any granulation tissue or hyalinization. So this is cognitive tumor necrosis, and you can see there's a diffuse atypia, which is of moderate type, and the numerous mitosis, which has already been shown. So this has three features of Stanford criteria and mitosis, which are about 22 in more than 20 in 10 hyperfield. So this is a clear-cut case of leiomyosarcoma. However, it has arisen in a leiomyoma as there is a malignant transformation in a leiomyoma, which is a rare entity. So just to show the difference, when you have a lot of nuclear atypia, when there is a diffuse nuclear atypia, but no increase in mitosis or no necrosis, we call it a symplasmic leiomyoma. When there is no atypia, it's called a mitotically active leiomyoma. When it has diffuse atypia, but the mitosis is not enough, like not more than 10, it's less than 10, for example, and no necrosis, then a smooth muscle tumor of uncertain malignant potential. This is very important in categorizing smooth muscle tumors. So these 3 points, whenever you get a leiomyoma, always assess these three features. So mitosis most of the time, because leiomyoma is so common, PGs just put the slide under the microscope and just pass it off as a routine. Always look for mitotic figures. Count the mitotic figures at least in 2 or 3 areas and comment that there is infrequent diagnosis. The take-home message from this is always sample large fibroids to avoid missing any focal malignant areas. Apply the Stanford criteria strictly before labeling as leiomyosarcoma because is an intermediate diagnosis. Have the required 2 points of the Stanford, then we could call it as a stamp of. Thank you.
Thank you, ma'am. Now we move on to the next case. We'll be discussing long case number 1 next, and it will be discussed by Dr. Syed Misbah from Mysore Medical College. Dr. Syed, have you joined?
Chandrika, please stop sharing the screen so that yes, I yes, Lekhan, please share your screen.
Yes, sir.
Dr. Syed, please note you will get only 7 minutes for your presentation.
Is it visible? Is it visible now?
Please go ahead.
Yes, it is visible.
I am Syed Misbah, postgraduate student from Mysore Medical College. I was allotted this case. A 67-year-old female. CT abdomen shows heterogeneously enhancing lesion with cystic areas and solid elements measuring 8 cross 6 cm in left suprarenal region, abutting the splenic well and tail of the pancreas, suggestive of adrenal neoplasm. CAE was 1.1 and CA 19.9 was less than 2 microperliter. These are the microscopic images. Coming to the microscopy, we can see section studies show a tumor composed of proliferating gland-like and vascular-like spaces lined by flattened to cuboidal cells, predominantly arranged in a cystic pattern followed by angiomatide and solid architectural patterns. The tumor cells exhibit clear to eosinophilic cytoplasm with focal cytoplasmic vacuolation simulating signet ring-like features, all set within a fibrous connective tissue stroma. Also noted are thread-like bridging strands, areas of hemorrhage, and hemosiderin-laden macrophages. Interspersed within the tumor cells are entrapped morphologically unremarkable adenal cortical cells. So these are these vascular spaces. There are multiple. And here we can see signet ring cells. This is that intracellular bridging pattern. This is areas of hemorrhage and hemosiderin-laden macrophages. We made an impression of adenomatoid tumor, the left adrenal gland. Following were the differential diagnosis, endothelial cyst and lymphangioma. And for further confirmation, you can do IHC. Adenomatous tumors show positive stains for calretinin and mesothelin. Epithelial stains like AE1 and AE3 are positive. And CD31 and CD34 are negative, which will be positive in endothelial cyst and lymphangioma. Lymphangioma and endothelial cyst can be differentiated by doing photoplanin D240 stain. Thank you.
Thank you, Dr. Sayed.
You can stop sharing later.
This case will be discussed by Dr. Vidya Monappa, Additional Professor of Pathology from KMC.
Is my screen visible?
Yes, ma'am. Put it on slide show mode.
Okay. Okay, good afternoon, everybody. I'm Dr. Vidya from KMC Manipal. I think there has been some, change in order of the slides. Anyways, Dr. Syed. Okay, not this case, no? Sorry. Okay, so this case, like Dr. Syed already mentioned, it's a 67-year-old female with a heterogeneously enhancing lesion with cystic and solid elements measuring around 8.68 by 6 centimeters. Kindly note the CEA was normal, CA99 was also within less than 2 units per ml. But the CT was suggestive of an adrenal neoplasm. I have not actually, we got the resection also, but this is how we got the case. Okay, and this is the CT image. As you're seeing here, it's a nice cystic, solid cystic lesion, lytic lesion that is seen here. And these were the biopsy that we're finding, and I think he has done a good job. He has described, but Dr. Syed has called this as vascular spaces. We'll see later. As you're seeing here, you're seeing multiple cystic spaces. Okay, and you have this these are all lined by, and then there is this fibrous stroma in between, and these cysts are lined by bland looking cuboidal cells with uniform round nuclei. And as you can see further, I'm not seeing any mitosis, not much of pleomorphism, no necrosis also seen. And what is striking is this presence of nice blood vessels. The intervening stroma shows nice proliferating capillaries. There's another area, so again, cystic areas, and then the wall showing all these proliferation of this bland cuboidal cells with clear cytoplasm. And here is one big vessel that you're seeing here. So even we were a little lost as what could this be. And since there were clear cells, we thought, okay, let's put an inhibin stain, and it did stain. You can see it's not stained everything, but scattered cells are positive. CD34 and SMA is just highlighting the blood vessels, and CK is nicely positive. Now, based on these, Dr. Syed, of course, we did certain other markers like synaptophysin, which was negative. We did an HMB45, thinking that it be a clear cell clear cell sarcoma kind of thing, but they were all negative. Yeah, but I think he has given a DD of adenomatoid tumor. However, adenomatoid will not show inhibin positivity. CK could be positive. So this was our diagnosis. It's a serous microcystic cystadenoma of the pancreas. Now, after this diagnosis, we received a distal pancreaticosplenectomy specimen. And as you can see here, this is the spleen. This is part of the distal pancreas, and this is the lesion. Okay, and as you're seeing here, it has got a microcystic. You can see that it's got a slightly spongy cut surface. Going further, you can see the normal pancreas on the left hand side, and then you have this tumor composed of again the same picture that we got on the biopsy, multiple microcystic spaces lined by those bland cuboidal cells. And then there is this stroma, the fibrous stroma in between. Another picture showing the same thing, the high power. As you can see here, they are nice cuboidal cells with uniform bland nucleus, granular chromatin, and this clear cytoplasm. So we held on to the same diagnosis. There was no change. So it's a serous cystadenoma of the pancreas. We all know that it's a benign neoplasm, and they contain glycogen-rich cytoplasm. It's not very common. I think in the last 5 or 6 years, we may have seen some four cases. It accounts for 1 to 2% of pancreatic neoplasms, common in the 6th decade in females. And some cases have germline alterations in VHL gene. Now, we don't know whether our patient or had a VHL syndrome because he did not have lesions in the CNS or in the kidney or anything else. So this was just an incidental finding that where inhibin was put, it stayed positive. These are associated with excellent prognosis. Okay, there's nothing much to discuss about serous cystadenoma, but yes, you should know what are the common cystic lesions of the pancreas. There are many more, but I'm going to restrict on to this. And what are the various biomarkers that are available? What are the newer advances, and what are the molecular biomarkers that are available? Of course, you know, cirrhosis associated with chronic pancreatitis, or it could be secondary to trauma or in a patient with alcohol consumption. They can occur anywhere, but they are common in the tail. Radiologically, they are unilocular or multilocular. And look at this. Since the cirrhosis could have linked to the pancreatic ducts, the amylase will be elevated. Glucose is also elevated. The CA99 and CEA are not really elevated. No molecular biomarkers are available, and the risk of malignancy is none. Serous cystic neoplasm, like exactly how our patient presented in the 5th to 7th decade, asymptomatic. Our patient had just mild abdominal discomfort. 60% of the cases occur in the body and the tail. On radiology, they are multilocular, multicystic with a spongy appearance, which we saw on the gross, with the central scar. Now, central scar is a very characteristic feature of serous cystadenoma. However, it is present only in around 30% of the cases. Now, serous cystadenomas do not have, or serous cystic neoplasms are not connected with the pancreatic duct. That's why you do not get elevation of serum amylase. So amylase will be within normal limits or slightly lower. CEA can be slightly elevated, but CA99 is decreased. Glucose is normal or slightly increased. What is the molecular biomarker? It could be associated with VHL. Like was seen in our case, but we don't know. We have not done a molecular testing for VHL gene, but we did get an inhibin positivity. Risk of malignancy is low. Very rarely you can get serous carcinomas arising from it. The next important lesion that cystic lesion of the pancreas that you should know is the intraductal papillary mucinous neoplasm. Again, could be asymptomatic, again in the same age group, 5th to 7th decade, but there is no sex predilection here. Unlike the serous cystic neoplasms, 50% of them arise in the head. Again, unilocular, multilocular, but they could have solid elements. Since IPMN arises in the duct, you will see that the serum or the cyst fluid amylase will be elevated. Glucose is decreased. The CA99 and CEA is elevated. Now, what are the newer molecular biomarkers? What they're doing currently is they are sampling the cyst fluid and testing for all these molecular markers. So KRAS, GNAS, TP53, and BRAF could be mutated, and the risk of malignant change is high. Mucinous cystic neoplasm, slightly younger age group for 4th to 6th decades, again exclusively in females. Look at the site. This is more common in the tail. It is usually unilocular with a thick cyst wall, and almost 25% of them will show eggshell calcification. Again, mucinous cystic neoplasm is not connected to the pancreatic duct, so the amylase levels is not really elevated. Glucose is decreased. The CA19-9 and CEA are, however, elevated. Look at the molecular profile, molecular biomarker that could be done here. KRAS is common to both IPMN and mucinous cystic neoplasm, but you can do the other markers like SMAT4 or CDK and B1. That will be positive here. Malignant potential is high. Then you know the SPEN is not really a benign tumor. It is considered to be a malignant tumor, but it has only a locally aggressive nature. So when I say variable malignant potential, this I mean to say the risk of metastasis. Okay. Now this, unlike the other pancreatic cystic neoplasm, this occurs in young females, common in the tail, has a solid cystic heterogeneous appearance on radiology. It can also show eggshell calcification. Again, since it is not opening onto the ducts, the amylase levels are decreased, and the glucose levels are normal. So the CA19-9 and CA are not really contributory here. And there's one molecular biomarker, that is the CTNNB1. Then that is the cystic NET or the neuroendocrine tumor. This is again mostly asymptomatic. It can arise anywhere, but it is said that it is commoner in the head. It could be solid. Remember, NET can present as a solid mass as well. But this, when it presents as a cystic mass, then it comes as a DD for your cystic lesions of the pancreas. Here, it's just like SPEN. It has none of these markers are of any contribution. It may be associated with MEN1. And the risk of malignancy is again variable. So this is just to summarize that, okay, when you get a cystic lesion of the pancreas, yeah, the radiology may not really be contributory like it happened in our case. We didn't know that it was from the pancreas, but the morphology is very typical, and we got some markers which was favoring the diagnosis. This is just for completion. Now, this is a case of an IPMN. You have these dilated ducts with this proliferation of epithelium. Now, what is important here is to look for the presence of dysplasia. This is mucinous cystic neoplasm. Characteristic feature of mucinous cystic neoplasm is the presence of ovarian type stroma in the subepithelium. Okay. And this is SPEN, which has a pseudopapillary appearance with the cells appearing to fall off from the other thing. You have a characteristic immunohistochemical profile, which is, I think beyond the scope of the discussion here. Okay, yes, thank you.
Thank you, Dr. Vidya. This was actually long case number 2. So now we go to long case number 1, which will be presented by Dr. Lekhan from ESI Medical College, Bangalore.
Yes, ma'am. It's visible, ma'am?
Yes, it is visible.
Okay. Good afternoon, everyone. Myself, Dr. Lekhan AS, second year PG from ESI Medical College. I highlighted case number long case 1 or slide number 10. Case history with a 59-year male, multiple indurated plaques on forearm. We received one digitally scanned histopathology slides having 2 sections of skin tissue for discussion. In low power wheel, we saw like section showing 2 sections of skin tissue. In 5x magnification showing epidermis and dermis. Epidermis showing a follicular plugging and effacement of rete ridges. In 10x view, we can see section shows a thinned out epidermis with busy dermis. Busy dermis showing dense infiltrate of blue cells, possibly of lymphoid origin. There is a infiltration by atypical lymphocytes prominently seen in the dermo-epidermal junction. There was epidermal tropism can be seen. And the most of the infiltrates are in the dermis. Then there is a formation of fortuitous microabscess. This is the collection of atypical lymphoid cells in the dermo-epidermal junction. The infiltration The infiltration by atypical lymphoid cells span almost entire dermis. These cells are medium to large sized or round to oval in shape with a nuclear hyperchromasia and irregular nuclear membranes, few with prominent nucleoli and scant cytoplasm. There is also like atypical lymphoid cells also display prominent halo around the nuclei. Then there you can see like atypical mitosis are noted for like 3 to 4 from high power field. This showing atypical mitosis, some caterpillar like atypical mitosis noted. Summary of the case: epidermis is thinned out with focal areas of follicular plugging and effacement of ratty ridges. There is infiltration by atypical lymphocytes prominently seen in dermoepidermal junctions, some of them extending into the epidermis. The infiltration by atypical lymphocytes cells span almost all the entire dermis. These cells are medium to large size, round to oval in shape, with the nuclear hyperchromasia, irregular nuclear membrane, few with prominent nuclear and scant cytoplasm. Atypical mitosis noted were 3 to 4 for high power field. There is a atypical lymphoid cells also display prominent halo around the nuclei. Then proteolytic microscopes was present and a Grange zone was absent. There is no evidence of epidermal necrosis or fibroplasia. No substitutes provided in the section studied. Depending upon the slide provided, we came to our diagnosis like primary cutaneous T cell lymphoproliferative disorder. I would like to give differential diagnosis like mycosis fungoides, lymphomatoid polyposis, maybe type B and D, adult T cell leukemia lymphoma, primary cutaneous CD8 plus aggressive epidermotropic T cell lymphoma, and primary cutaneous gamma delta T cell lymphoma. Why it is T lymphoid proliferation means T cell infiltrate will have top heavy infiltrate and band like infiltrative pattern will be there compared to B cell that will have nodular infiltrative pattern. Then T cell will show epidermotropism and follicular tropism. In this case, only epidermotropism was present and Grange was absent. In B cell infiltrate, epidermotropism, follicular tropism will be absent, and Grange usually separates the dermal infiltrates. Then coming to the individual differential diagnosis, mycosis fungoides usually occurs in 5th and 6th decade. Multiple plaques will be there, and presence of epidermotropism and band like atypical lymphocyte infiltration and Portreous microabscess present. Medium to large size atypical lymphocyte with nuclear hyperchromasia, irregular nuclear membrane, few prominent nucleal and atypical mitosis and halo around the lymphocyte noted. There was no necrosis. There will be loss of CD7 will be there in mycosis fungoides. Other differentials like lymphomatoid polyposis, it will be like 35 to 45 years. You will see usually there will be waxing and waning of lesions and papillonodular lesion. Usually, if your clinical history is more, you can distinguish between mycosis fungoides and lymphomatoid polyposis. There will be waxing and waning, and there will be fibrin and fibrin thrombi in dermal capillaries and dermal edema. Adult T cell leukemia lymphoma will present mainly as nodular tumor. Primary cutaneous CD8 plus aggressive epidermotropic T cell lymphoma occurs at any age group. Diffuse involvement of skin with erythematous necrotic plaque will be there. There will be spongiosity and epidermal necrosis will be there. Usually angio-invasive and involves subcutaneous also. Cutaneous gamma delta T cell lymphoma, they're very rare. 63 years median age will be there. Scaly patches plaques present as a deep subcutaneous nodular tumor. Final diagnosis, I like to give primary cutaneous T cell lymphoproliferative disorder of the forearm. These are my references, and thank you.
Thank you, Dr. Lekhan. Now I invite Dr. Kantirata Pai to discuss this case.
Am I audible and visible? Is the screen seen?
Yes, ma'am.
Presentation. Your approach with regards to this case is good, but I would like to highlight certain points. So, as you rightly mentioned, these were the differences you said between how to differentiate a T cell lymphoproliferative disease from a B cell. So, this is from your point. So, this is how it is. So, if you can see on the left side is a T cell lymphoproliferative, because what you're seeing is an infiltrate which is in the upper epidermis, almost hugging the epidermis with epidermotropism. You see the presence of these lymphocytes in the epidermis, which are also forming these abscesses. So on the left side is a T cell lymphoproliferative, and you don't see a Gren zone in the T cell because the lymphocytes infiltrate the epidermis. Whereas on the right side is a B cell where it is a bottom heavy. You see a clear zone of collagen or a Gren zone which separates the epidermis from the infiltrate, and you don't see epidermal infiltration or epidermotrophism. So that's the first thing when you see a lymphoid proliferative disorder in the skin. To decide whether it is a T or a B, these points are helpful. Now, coming to epidermotropism, which is a feature of T lymphoproliferative disorder, a very important is to differentiate it from exocytosis. I don't know why that exocytosis image is hiding behind the other. Nevertheless, you see in T lymphoproliferative disorder, you see these lymphocytes which are going to the epidermis and they are surrounded by a clear halo. And you don't see that much spongiosis, which you see in the figure on the right. Because even in inflammatory conditions like dermatitis, you get lymphocytes going into the epidermis, in which case you call it exocytosis. You don't call it epidermotropism. You call it exocytosis, and there'll be marked edema, intercellular edema or spongiosis. So that's how you differentiate epidermotropism of lymphoproliferative disorder from exocytosis. So in case of cutaneous T-cell lymphoma, the epidermotropism is out proportion to the little edema that may be seen, whereas in inflammatory condition, you see marked intercellular edema and a few lymphocytes. Whereas in epidermotropism, you see a halo or a clear zone around the lymphocytes. So now the working diagnosis, this is the working diagnosis that is given by Dr. Lakan. So primary cutaneous lymphoproliferative disorder, you put mycosis fungoides as your first differential, and these were the others. This was my working diagnosis, that is mycosis fungoides. If you all remember the image, what we saw is a lot of large cells. You saw a lot of lymphoid cells, and many of them were large. Dr. Lakan, again, you said mycosis fungoides, you get medium to large cells. It is not. Mycosis fungoides, the infiltrate usually is small to medium size. They almost look like mature lymphocytes. Many times in the early, as you all know, the mycosis fungoides progresses from patch to plaque to nodules. So in the early patch stages, they look so much like a normal lymphocyte. So it is very easy to misdiagnose or miss it in the early stages. So, whereas in our case, we saw that more than maybe 30 or 40% were large cells. So, if it is a mycosis fungoides, it is not just a usual mycosis fungoides, it is a transformed mycosis fungoides. So, that was my first DD. Second, which you have not listed in your differential diagnosis, is primary cutaneous anaplastic T cell lymphoma. You did mention about CD8 positive aggressive cutaneous T cell lymphoma. Then, of course, the other T lymphoproliferative disorders that were also in my mind, whether it is lymphomatoid papillosis, adult T cell leukemia lymphoma, or gamma delta. So these are all the differential diagnosis you should have when you are considering a T cell lymphoproliferative, and then go in a systematic manner considering the clinical histopathology and the immunohistochemical features. Now, mycosis fungoides clinically progresses from patch to plaque to nodules. In our case, the patient gave a long history of the lesions progressing slowly over many years. So that is something which goes in favor of a mycosis fungoides, unlike anaplastic T cell lymphoma that was the other differential. So the history, patient had this history for many years. Typically, mycosis fungoides occurs in the bathing distribution, whereas in our case, the lesions were mostly in the extremities. Now, histopathology normally shows small to intermediate cells. You can see that they almost look like small lymphocytes. This is not our case. I'm just showing a usual mycosis fungoides. This is how it appears. You see the cells, they almost look like small lymphocytes, maybe slightly bigger. You see them in the upper epidermis and then epidermotropism and forming some diarrhea porphyria abscesses. So if you have more than 25% of large cells, then it is likely to be a transformed MF, which usually happens when the lesions have been there for many years. The primary cutaneous anaplastic lymphoma, the other differential that we have to consider in this case, clinically could be because it shows plaques and nodules. Histopathology, what we see is a lot of large cells and the typical hallmark cells that you also see in nodal anaplastic lymphoma. And usually there are some admixed eosinophils and neutrophils, which we do not see in our case. Epidermolysis is usually not a feature of ALCL. So however, it can be seen in some cases. And this one, IHC will be CD30 positive. And unlike the nodal anaplastic lymphomas, which are ALK positive, the cutaneous lymphomas, ALCL, is ALK negative. Lymphomatoid papulosis, the other DD that you mentioned, the B and the D types, can very closely mimic cutaneous T-cell lymphoma. But in this case, clinically, lymphomatoid papulosis has a very benign course. Patients usually have self-resolving and recurring lesions, so this did not fit in our case. Moreover, lymphomatoid papulosis is usually seen in younger age group. So this is lymphomatoid papulosis. You can see it can very closely mimic CTCL or mycosis fungoides with the top heavy infiltrate and epidermotropism. And in this case, you have CD30. So in the skin, CD30 positive lymphoproliferative disorders include lymphomatoid papulosis and ALCL. So in this case, you can see a lot of CD30 positive cells. So other differentials are CD8 positive aggressive T-cell lymphoma, which, as Dr. Lakan mentioned, there are ulcerated lesions with epidermal necrosis. Histopathologically, you see large cells epidermostropism, so could be, but there is no ulcerated lesions or epidermal necrosis. The gamma delta type of T-cell lymphoma also can mimic MF, but it usually goes deeper into the subcutaneous and they're CD56 positive. Adult T-cell leukemia lymphomas usually occur in certain geographic areas like Caribbean or Japan. I have not seen any case being reported in our setting. And this also mimics mycosis fungoides, and you need a HTLV testing for the diagnosis. So in this case, one thing that was missing in your presentation was you made a diagnosis of T-cell lymphoproliferative, agreed, but you have to suggest the IHC workup, because now going down with all these differentials, the only thing that can solve and come to the diagnosis is your IHC workup. So in this case, we would first do a 3 and 20 to know whether uh, the uh, the the histopathology which showed T cell is actually T cell, because you can have these overlaps sometime, and then you proceed further. So this is the first. You can see the CD3 and the 20 in our case. So it was strongly and diffusely positive to CD3, establishing our primary diagnosis of T cell lymphoproliferative disorder. We can only see few scattered CD20 B cells. So that's a T cell lymphoproliferative. So now we are T cell lymphoproliferative. We want to know whether it's a T helper cell subset or a CD8. So we have the CD4 and the CD8 here. You can see all the infiltrate is all CD4, and CD8 are few scattered cells there. So normal CD4 to CD8 ratio is 2:1, and anything more than 10 is considered to be a feature of cutaneous T-cell lymphomas. So in our case, this predominantly CD4 cells, and you can see actually when you compare the CD4 and the CD8 ratio, it is to be done in the epidermal region, not in the dermis. So even in the epidermis here, you can see the epidermotrophic lymphocytes are all CD4. The next thing that I asked for is CD30, because the diagnosis differential I had was primary cutaneous ALCL, and this you can see is diffusely CD30 positive. So in mycosis fungoides, CD30 is only negative, or maybe few scattered cells may be positive. Among the CD30 positive cutaneous lymphoproliferative are the lymphomatoid papulosis and the ALCL. However, in this case, lymphomatoid papulosis is unlikely because it's an older patient and there's no history of spontaneous regression in the past. So now with the CD30 positive lymphoproliferative disorder, the differentials would be mycosis fungoides is usually CD30 negative, but a transformed MF can show diffuse 30 positive. So now the other two differential that I just mentioned when we have diffuse CD30 positive is ALCL and lymphomatoid papulosis. So I did a ALK just to rule out ALCL, even though cutaneous ALCL is negative, to rule out a metastasis from a nodal ALCL. So this is ALK negative. CD56 would be positive in a gamma delta lymphoma. This also was negative. So with this, my final diagnosis was mycosis fungoides with large cell transformation, and mentioned about CD30 positivity because knowing that there is a monoclonal antibody, the targeted therapy for CD30, and KI67 also helps in prognostication. So large cell transformation should be reported when there are you have cells which are more than 4 times the size of the small lymphocyte, and I advise for molecular studies for a final diagnosis. So the take-home message in this case is whenever you get a lymphoproliferative disorder, look at you should have a systematic approach. Look at the age. MFS usually occurs in elderly patients. Lymphomatoid papulosis and ALCL are in younger. Background, look at the ethnicity if they are from the Caribbean or Japan. So it's unlikely in India to have adult T cell leukemia lymphoma. Look at the clinical picture. If it is a regressing lesion, then it is lymphomatoid papulosis. If it's a long standing in the bathing trunk, it's usually MF. Consider all the differentials as I listed, and the final evaluation is with histopathology and immunohistochemistry. Thank you. Any doubts in this?
Thank you, ma'am, for the detailed discussion of the case. Now we move on to the spotters. We'll finish the spotters first. So next we have spotter number 2, which will be presented by Dr. Akshata from Father Muller Medical College. Kanti ma'am, you can stop sharing your screen.
Sorry.
Dr. Akshata?
Yes.
You can switch on your video and you can share your screen. Please note you will get 5 minutes for presentation.
Good morning, everyone. Good afternoon, everyone. I'm Dr. Akshata from Father Muller's Medical College. I'm gonna present case number 2, spotter. Case history was given as 60-year-old female, left axillary lymph node enlargement. This is the scanner view of the slide, which shows maintained lymph node architecture. And on higher magnification, it shows enlarged multiple varying sized and shaped follicles, and with the prominent germinal centers, and shows tangible body macrophages here, and also noted a expansion of sinuses by the histiocytes. On high power shows expansion of histiocytes.
Dr. Akshata, have you put it on slideshow mode?
Yes.
Okay. Because for me it is not visible. Is it visible to everyone? Okay, you can continue.
Okay.
It's not visible, ma'am. She should do slideshow.
Please put it on slideshow mode.
I have put it on my slideshow. Is it visible now?
No, now your screen is not visible. Please share again.
Okay.
Unshare and share again.
Okay. Now, ma'am?
Yeah, your screen is visible, but put it on slideshow mode.
I have put it on a slideshow. Is it visible?
No, so Swati, Dr. Swati.
No, ma'am, it's not it's not visible. It's,
Please click on the slideshow mode because we are seeing it in down
Share
now.
the entire screen.
you have to do share.
Please share entire screen, not just the PPT.
Okay.
Share entire screen.
Stop sharing and reshare.
Okay.
While you're clicking on that, go to entire screen.
Okay, ma'am.
Okay, now you put it on slideshow mode.
From beginning.
Is it coming, ma'am?
No, it's still not coming in the slideshow mode.
I'm putting in a, I don't know.
You have clicked on share entire screen, right? Click on the button below that umbrella like button. Yeah, next to that. Yeah, next.
Yeah,
Just yeah.
I have clicked on the slideshow.
Yeah, but it is still in the same mode. Dr. Swati,
Yes, ma'am.
is it visible in the slideshow mode?
No, ma'am, it's not.
Uh,
She has to individually click on the slide, I think, at least if she can't do that. I
yeah,
mean,
because the slides are not moving, Dr. Akshata, when you're presenting. So you have to click on each slide when you move to the next slide.
Okay, ma'am. Is it okay, ma'am? Like this?
Yeah.
Okay.
Yeah.
Good afternoon. I'm Dr. Akshata from Father Muller's Medical College, and I am presenting case number 2. And case history was given as 60-year-old female, left axillary lymph node enlargement. Microscopically on scanner view, lymph node shows maintained architecture, and it shows reactive follicles, which is of varying size and shape. And on higher magnification shows follicles with prominent germinal centers and shows tingible body macrophages in each prominent germinal centers. And also noted a expansion of sinuses by the histiocytes. And in a high power expansion of sinuses by histiocytes. So, but I also noted a subcapsular some glandular area. I wanted to think it as a metastatic also, but I was not sure. And so summary of my presentation is sections from the lymph node shows preserved architecture, prominent reactive follicles, hyperplasia is noted, and follicles with well-formed germinal center containing tingible body macrophages are also noted. Sinuses are expanded by numerous histiocytes with abundant pale cytoplasm admixed with small lymphocytes. No evidence of granuloma, necrosis, or malignancy seen in the section study. So, with all these features, I'm giving the diagnosis of features of reactive lymphadenitis. So, the DDs for reactive lymphadenitis can be granulomatous lymphadenitis. In this, we can granulomatous lymphadenitis. We see epithelioid cell granulomas with caseating necrosis in TB and non-caseating necrosis in sarcoidosis. It can be also Hodgkin's lymphoma, where we can see the lymph node architecture is effaced, and also we can see Reed-Steinberg cells with a mixed inflammatory background. But in non-Hodgkin's lymphoma, we can see diffuse nodular proliferation of monomorphic typical lymphocytes, which was a differentiating feature from the reactive lymphocytes. So the final diagnosis is reactive lymphadenoma. Yes. Thank you.
Thank you, Dr. Akshita. Now I invite Dr. Swati Prabhu, Assistant Professor of Pathology, KMC Manipal, to discuss this case.
Yeah. Is the slide visible? Am I audible?
Yes, you are
Okay, good.
audible and visible also.
Yes.
Slide is
Thank you.
visible.
Thank you, ma'am. Good afternoon. I'm Dr. Swati from KMC Manipal. So this was a history that was given 60-year-old female left axillary lymph node enlargement. So history that I didn't provide was patient, mainly it was a patient of left carcinoma breast where they had done mastectomy, now had lymphadenopathy and they were suspecting metastasis. So this was the slide that was provided. As we see here, entire cross cut section of the lymph node is there, and I can. One point was missed actually in the diagnosis which Akshata gave was okay. I agree there was a lot of reactive follicles and of varying sizes. There was sheet of monocytoid cells, and then in between these cells, I mean the follicles, we saw these clusters of cells, okay, which had this little epithelioid looking nucleus, had abundant cytoplasm, and it was a cluster of 10 to 15 cells which was microgranulomas. So it was not the sinus actually, so it was in between the paracortical area. Sinus, we are supposed to see some vasculature, some lymphatic, some blood vessels, some RBC, so that we call it as sinuses. But this was right within the parenchyma, like paracortical areas, where there was clusters of these cells which had little indented nucleus, and they had little elongated nucleus and eosinophilic cytoplasm. So these were microgranulomas which was present in the cortex and the paracortex region. Apart from that, there was sheet of these monocytoid looking cells which had little clear cytoplasm, little big nucleus, enlarged cells, and with a characteristic clear cytoplasm. So, based on this, the following differentials, of course, reactive we have to consider the first thing, and in that there are a lot of other things. With the microgranuloma in the picture, we have to rule out sarcoidosis, TB. TB, of course, will have a proper, well-defined granuloma and a necrosis by multinucleated giant cells. Leishmania, syphilis, toxoplasmosis, even a tumor-reactive lymphadenopathy can have these features. And then the Lennart lymphoma. Lennart lymphoma is T cell lymphoma, that is PTCL with the microgranulomas. So the diagnosis actually, this came to us. I had suggested two diagnoses for them. Of course, first I told them rule out tuberculosis, and the second diagnosis was I asked for serum IgG and IgM levels for toxoplasmosis. And the first they did a core biopsy, and they didn't. They just checked for TB, which was PCR negative, and then they did a excision biopsy. Again I reported it as please check for IgG IgM toxoplasmosis. After the repeat excision, they after that they checked for the IgM IgG levels, which we came to be positive for toxoplasmosis. So this was a case of toxoplasmosis lymphadenopathy, and the it is caused by a protozoan toxoplasmosis gondii. The definitive host is cat, and the intermediate host is humans. So mainly in an immunocompetent individual, we find just a localized lymphadenitis, whereas it can be disseminated if the patient is immunodeficient. Also, when there is a severe immunodeficiency, they can present myocarditis, pneumonitis, encephalitis, which might lead to death. The posterior cervical lymph node is the most common site, but since our patient was a case of carcinoma breast and was little bit immunocompromised, was on chemotherapy, so maybe the axillary presentation was atypical. However, the histopath was very typical of toxoplasmosis gondii. So cervical, supraclavicular, occipital lymph nodes also can be involved. On examination, we don't find it. The lymph node enlargement will be there. They're not hard, but they're just firm in consistency. So the triad, they say, comprising of reactive follicles of varying sizes, clusters of epithelioid cells, especially located in the paracortical area, which might even approach the germinal centers. And we call a microgranuloma when there are collections like less than 25 histiocytes. You're not supposed to see any necrosis, neutrophils, or eosinophils. If you see a well-formed granuloma with necrosis, of course, your diagnosis has to go in direction of tuberculosis in Indian settings, especially. And there are no multinucleated giant cells also in this condition. Very rarely, less than 1% of the cases, we can see toxoplasmosis cysts or bradyzoids. And the medullary cords will have some plasma cells and immunoblasts. So 1% of the case only you can see the trophocytes, which can be free or within the macrophages. And if you see them, usually it is the invasive forms. So that how do we diagnose these cases? If you histopath may be suggestive of toxo, but for confirmation you might have to do IgM, IgG antibodies. IgM suggests of acute infection. IgG is usually delayed infection or old infection. And in the case of congenital toxoplasmosis gondii, PCR is detected, can be used. And also there is also IHC that is available. We don't have that. So which is a plasma antigen that can be used for diagnosing this condition. So if you consider the DDs, sarcoidosis, usually you see a well-formed naked granulomas. Leishmania also comes into a diagnosis, but in that you might see a lot of multinucleated giant cells. There can be necrosis, there can be fibrosis, and also you can see some histiocytes which contains LD bodies within the cytoplasm. A lot of lymph nodes that has been removed for tumor, that also might show this reactive lymphadenopathy, but the characteristic triad, that is the monocytoid, usually is not seen. Microgranulomas to some extent can be present, but the monocytoid sheets of monocytoid cells with reactive follicular hyperplasia and microgranulomas present, we call it a classic triad of toxoplasmosis, usually will not be present in the tumor reactive lymphadenopathy. We also have to rule out a lymphoma in this condition, and that is when we use especially CD3 or CD20, when there is sheets of CD3 Lennart lymphoma, that is a PTCL with microgranulomas, has to be ruled out. And sometimes a Hodgkin lymphoma can come into a diagnosis if you like some RS like cells, if present, might with Hodgkin lymphoma also, especially you have to rule out Hodgkin lymphoma in this, and you have to search for RS cells before you label the slide, the diagnosis as reactive or toxoplasmosis. So that will be, thank you. This is from case 1, case 2, spotter. Any doubts in this one? Chitra?
Thank you, Dr.
Hello,
Swati.
Yeah.
Now we move on to the next case, spotter number 3, which will be presented by Dr. Reshma from Yenepoya Medical College. Dr. Reshma. Dr. Reshma, have you joined? Yes, Dr. Reshma, please put on your mic. You can also switch on your video. You'll get 5 minutes for presentation. Put on your slideshow mode. Dr. Reshma, you're not audible. I think Dr. Reshma is having some technical issues. Dr. Reshma? Am I audible?
Yes, ma'am, you're audible.
Okay, I think we'll move to the next case, quarter number 4, which will be presented by Dr. Mohammad Rafi from Mandya Institute of Medical Sciences. Dr. Mohammed, are you there?
Yes.
Yeah. Please put on your mic as well as video and you can share your screen. You will get 5 minutes for presentation.
Is the screen visible, ma'am? Hello.
Yes, yes.
So good afternoon, everyone. Myself, Dr. Mohammad Rafi from Department of Pathology, MIMS Mandia. So I am allotted spot number 4, 19-year male duodenal biopsy. So this is the slide view. We can see here the picture. This is a 2x view. So coming to the scan 4x view, we can see prominent lymphoid aggregates within the lamina propria. So in 10x view, we can see the normal intestinal lining, epithelium with goblet cells nearby that prominent lymphoid aggregate. So continuously magnifying into 20x, we can see the gland. So a flagellated microorganism can be seen in the lumen of the gland. So that is the first region of interest. So coming to the second region of interest, in the 2x view, you can see that the crypt hyperplasia is there. So in scan view 4x view, we can see villus atrophy with crypt hyperplasia. So in 10x view, we can see prominent intraepithelial lymphocytosis in all of the entire slide. So coming to the second region of interest, we are seeing some kite and pear-shaped microorganisms. So from the histopathological findings, we are seeing villus atrophy, crypt hyperplasia, intraepithelial lymphocytosis, prominent lymphoid aggregates, and multiple pear-shaped microorganisms. So my DDs are celiac disease, tropical sprue, autoimmune enteropathy, and giardiasis. And the final diagnosis is giardiasis. So giardiasis caused by Giardia lamblia, Giardia or Giardia intestinalis or Giardia duodenalis is common in younger adults than younger individuals than adults. And in histopathology, it will be a pear-shaped or kite-shaped microorganisms seen between intervillous spaces and within the glands. So there is increased intraepithelial lymphocytes and increased inflammatory cells and prominent lymphoid aggregates in the lamina propria. Thank you.
Thank you, Dr. Mohammed. Now I'll be inviting Dr. Nishchita, Assistant Professor of Pathology from KMC Manipal, to discuss this case.
Good afternoon. Am I audible?
Yes.
Yes. Thank you, ma'am. Thank you, Dr. Mohammed Rafi. That was a good presentation. So I'll be discussing case 4. So the case provided was 19-year male duodenal biopsy. So this patient came to us with complaints of recurrent vomiting and failure to thrive, and clinically was suspected to have gastric outlet obstruction. So upper GI endoscopy was performed, which showed duodenal scalloping, and on CT enterography, features were suggestive of acute obstruction secondary to superior mesenteric artery syndrome, for which the patient underwent a surgery and was treated. Subsequently, from the duodenal biopsy was sent to us. So this is a low power image of the fragment of duodenal mucosa, where we can see that the villi to crypt ratio is maintained. The normal villi to crypt ratio is usually 3:1 or 5:1, and almost 4 consecutive villi appear normal. And also on low power, the lamina propria shows a mild lymphoplasmacytic infiltrate. Crypt appears unremarkable. And also there was a presence of lymphoid aggregate, which is highlighted in this circle. And the overlying mucosa overlying this lymphoid aggregate usually appears flat, but it should not be misinterpreted as a villus flattening. And on higher power, we can see that the mucosa and the villi appear normal. The crypt to villus ratio is maintained. Crypt hyperplasia is not evident here. It appears normal. Lamina propria is showing mild to moderate lymphocytes, plasma cells, and occasional eosinophils were also present. And intraepithelial lymphocytes was about 26 per 100 epithelial cells. There was no evidence of cryptitis, cryptapsis, or surface ulceration. Also, goblet cells were present in this particular biopsy. And what was striking here was the presence of these organisms which were present along the surface of the mucosa and along the villi, in between the villi, which are characteristic. It has a very classic appearance of a fallen leaves appearance, and you can see on higher power that these organisms are pear shaped or sickle shaped, like crescent shaped organisms. And on higher power, we can demonstrate that these organisms have paired nuclei, two nuclei with crescent shaped or pear shaped organisms. Sorry. So these organisms are features are suggestive of giardia. So microscopy findings, to summarize, the duodenal biopsy showed maintained crypt to villus ratio. Lamina propria shows mild lymphoplasmacytic infiltrate. Lymphoid aggregates are seen, but there is not marked lymphoid proliferation. So this finding is also normally seen in a duodenal biopsy, and scattered eosinophils are present. Surface of the villi and mucosa are showing numerous pear-shaped organisms with two pale eosinophilic nuclei. And intraepithelial lymphocytes were mildly increased. That is, it was within 30, not marked increase in intraepithelial lymphocytes. These organisms were highlighted by trichome stain, and other features like mucosal ulceration or cryptitis, cryptapsis, villus atrophy, or loss of crypts were not evident in this biopsy. PAS and GMS stains were performed, and they were negative for fungal organisms or viral inclusions. No granulomas were noted, and there was no features of ischemia or necrosis, and no features of inflammatory bowel disease or classic appearance of celiac sprue. And stool microscopy examination was also performed for this patient in view of recurrent vomiting and diarrhea. And the stool microscopy examination did not reveal any ova, trophozoites, or macrophages. They were negative. So, based on our histopathological findings and the classical appearance of these organisms, features are suggestive of duodenal giardiasis. So coming to giardiasis, it's an infection caused by Giardia lamblia, which is a flagellated protozoa. Usually these conditions are seen in underdeveloped areas and is transmitted by contaminated water or food. Patients are usually asymptomatic, but patients can present with a wide range of symptoms from mild abdominal discomfort or intermittent diarrhea, or in case of chronic giardiasis, patients can also present with features of malabsorption. Histological changes are non-specific. So the biopsy might appear normal or it can show patchy villus abnormalities. For example, in our case here, there is mild increase in intraepithelial lymphocytes and also some amount of inflammation is seen, but no classic evidence of villus atrophy. Whenever we visualize a duodenal biopsy, we should make sure that the orientation of these villi and crypts are oriented properly, because a tangential section can also be misinterpreted as a villus atrophy or flattening of a villi. And in this particular case, even though the histological changes were non-specific, diagnosis relies on demonstrating these trophozoites which are present along the surface of the villi. They are present on the surface and in between the villi, but there is no presence of invasion into the underlying mucosa. So these organisms are almost the same as the size of an enterocyte nuclei. They are sickle shaped or tear shaped organisms and have paired nuclei and 4 pairs of flagellae. These organisms on biopsy on HND can be misinterpreted as a normal shedded enterocyte or even presence of mucus. So identifying this paired nuclei is very important to make this distinction. There are certain special stains like trichrome stain with iron hematoxylin counterstain can be used to highlight these organisms, or even Giemsa stain can be used. And in certain studies, they have even demonstrated that CD117 immunohistochemistry also highlights these organisms. It can be used only if there are like very few organisms and high index of suspicion. But in a classic case like this, these IHCs are not recommended. Other ancillary tests which can be used or which is routinely performed when there is a clinical suspicion of giardiasis is stool examination. That is to demonstrate the presence of trophozoites or cysts. It can also be demonstrated in a duodenal aspirate. Other than these, certain tests like nucleic acid amplification techniques can be used, or stool antigen enzyme linked immunosorbent assay or PCR based assays can also be used, which are rapid tests to detect these antigens. So, in our biopsy, there was presence of increased intraepithelial lymphocytes but preserved villus architecture. So, certain differentials which come into the picture are: one is Marsh type 1 celiac disease, where there can be increase in where there is increase in intraepithelial lymphocytes like up to 30, and villus morphology is maintained. So that is one of the differential. And also Helicobacter pylori gastroduodenitis can present with similar features. Cryptosporidiosis, drug-induced injury, mainly NSAIDs, autoimmune enteropathy. In autoimmune enteropathy, there will also be loss of goblet cells along with increased intraepithelial lymphocytes, and some amount of villus atrophy can be present based on the extent of the underlying etiology. And immune deficiency. Under immune deficiency, giardiasis are associated with these immunodeficiency states. In case of common variable immunodeficiency, these patients can present with chronic diarrhea, malabsorption, and recurrent giardia. One finding which favors this diagnosis is the absence or decrease in the plasma cells in the lamina propria and very evident nodular lymphoid hyperplasia. So, looking for plasma cells in the lamina propria is important. If in case it is absent or decreased, we can suspect common variable immunodeficiency. Also, other entities like selective IgA deficiency, X-linked A gamma globulinemia, and hyper IgM syndromes are also known to be associated with recurrent giardiasis. So these are certain conditions. Giardiasis is ideally diagnosed by doing a stool examination, that is microscopic examinations to demonstrate trophozoites and cysts. But in case the stool examination is negative, then histopathological examination is like gold standard. It is the presence of these organisms on the surface which picks the diagnosis. Thank you.
Thank you,
Thank
Dr.
you, Dr.
Now we move back to spotter number 3, Dr. Reshma from Anapoya Medical College. Are you ready? Dr. Reshma? You are not audible, Dr. Reshma. Uh, I think we'll move on to the next spotter. Spotter number 5 will be presented by Dr. Chitra from JJM Davangere. Dr. Chitra, have you joined?
Yes, ma'am.
Yes, please put on your mic and video, and you
Yes,
can share your slide.
ma'am, is it visible?
Yes. Please put it on slideshow mode. It is on slideshow mode. Okay. You can start.
Good afternoon, everyone. I have got the spotter 5. The case is 33-year-old female with right forearm swelling. FNAC done outside and was reported as small round blue cell tumor. Clinical impression given was soft tissue sarcoma. So section studied from the tissue bit shows epidermis and dermis. Tumor can be seen centered in the dermis. Epidermis appears to be unremarkable. And in this section, we can see the Gren zone, which is uninvolved. The tumor area appears to be centered in the dermis with the nodular pattern and the intervening fibrous septa in between. Now coming to this slide shows the tumor cell arrangement in the solid sheet pattern of arrangement of the cells, where we can see the cells are round to oval, monotonous to monomorphic with high NC ratio, scant eosinophilic cytoplasm, fine granular dusty chromatin, and inconspicuous nucleoli. There is also seen high degree of mitosis, around 10 to 15 per high power field. There is also seen large amount of apoptotic bodies and tingible body macrophages. Then this slide shows the fibrocollagenous area in between. There's also seen lot of proliferating blood vessels with few showing plump endothelium. Lymphatic and blood vessels were seen. There is also seen the areas of hemorrhage. There were also noted a few duct to gland-like structures, which indicates the eccrine differentiation. There is also a possibility which indicates the multipotential stem cell origin of the tumor. So my diagnosis is Merkel cell carcinoma. The points favoring my diagnosis is the age, which mainly occurs in adult and elderly. The site is face and extremities. In our case, it was extremities. The gross appearance can be nodulated or ulcerated lesions. Microscopically, dermal or subcutaneous regions, and also we had FNAC report. My differentials were lymphoma, alveolar rhabdomyosarcoma solid variant, metastatic small cell lung carcinoma, and desmoplastic small round cell tumors. For lymphoma, we can have the CD markers CD45, CD20, CD79 as a B cell marker. The most common transformation is small lymphocytic lymphoma, which shows PAX5 positivity, but neuroendocrine marker will be negative for lymphoma and will be positive for Merkel cell carcinoma. Also, we saw Gren zone uninvolved, which excludes lymphoma. Then we have alveolar rhabdomyosarcoma. The solid variant shows the less alveolar architecture, which suggests it can be rhabdomyosarcoma. But again, we didn't see myoblast or strap cells here. Then we have metastatic small cell carcinoma of the lung, which we can differentiate on the basis of nuclear features and IHC markers. And then we have desmoplastic small round cell tumor. The solid pattern can mimic
the diagnosis. But again, we don't have the rhabdoid cells here, and also the IHC marker can help us differentiate it. Here are the IHC markers for Merkel cell carcinoma. So it will be pan cytokeratin positivity. Cytokeratin 20 will be positive, showing paranuclear dot-like patterns. Then neuroendocrine markers helps to confirm the diagnosis. So CD is 56, chromogranin neuron-specific enolase and synaptophysin will be positive. Negative markers which helps to exclude the mimic is TTF1, which will help to exclude small cell lung carcinoma. Then S100 will help to exclude melanoma. CD45 will help to exclude lymphoma. Other useful markers can be neurofilament marker of proliferation Ki67. And also we can see Merkel cell polyoma virus, large T antigen in the viral positive cases. Thank you.
Thank you, Dr. Chitra. Now I invite Dr. Vidya Monappa, Additional Professor of Pathology, to discuss this case.
My slides are visible.
Yes.
Okay. Excellent job, Dr. Chitra. I think you have made my job very easy here. Okay. You have covered whatever differentials and given up the IHC. That's a very good job done. Yeah. So, history, I think we all know that it was a young patient presenting with the right forearm swelling, and FNAC outside showed was suggestive of a small round blue cell tumor. Clinical impression was of a soft tissue sarcoma. We have already seen the images as Dr. Chitra showed, but I'm just trying to highlight here. The epidermis is intact. There is no ulceration. There is a nice clear Gren zone. So you have tumor in the dermis and also extending to the subcutis. So this is I couldn't cover the entire image, so you have to, this is a lower picture. You're seeing nodular arrangement, and there is some fibrous septa here and there. Otherwise it is diffuse sheets. Now let us look at the cells in that of concern. You're seeing sheets of somewhat discohesive cells. You're having this high NC ratio. I would rather call this as a stippled chromatin. There's no prominent nuclei and very scant cytoplasm. Like Dr. Chitra already showed, there was brisk mitosis, and then you had this apoptosis and this tingible body macrophages as well. Now, this was the edge. Whenever you are dealing with the tumor, I mean, you have to comment what is it an infiltrating edge? Is it, is it well circumscribed? As you can see here, this is a subcutaneous tissue, so it's gone deep down, but it is fairly circumscribed. It is unencapsulated, okay? And this is the surrounding tissue. Another picture showing the same. Look at the amount of mitosis that is here. Brisk mitosis, and the tumor comprised of sheets of cells, small round cells, stipple chromatin. The tumor is confined to the dermis, subcutis, and the overlying epidermis is intact. So with this, we had, it did look like a small cell carcinoma, right? So the differentials that we considered was a metastatic small cell carcinoma, Merkel cell carcinoma definitely, and just for completion, possibility of an Ewing sarcoma was also considered. And these are the IHCs that were performed. The CK20 showing the classic perinuclear dot positivity, diffuse cytoplasmic positivity for synaptophysin. Was an interesting finding. Even CD99 showed a perinuclear dot-like positivity. But then we looked up, perinuclear dot-like positivity has been described in Merkel cell carcinoma as well. So Ki67 was high, almost 40%. We did certain other markers to rule out. Even a Desmin was performed, which was negative, just to rule out the possibility of a RMS, because that was also in the differential diagnosis. This rules out even a desmoplastic small round cell tumor. TTF1 As we know, small cell carcinomas of the lung, so also extrapulmonary sites to a large extent express TTF1. And a PET CT was also performed, which did not show any lung lesion. NKX 2.2 was negative. So, based on all these findings, a final diagnosis of Merkel cell carcinoma was made. Now, is it enough to just call it Merkel cell carcinoma and leave it like that? No, you have to comment on what is the stage of the tumor. Now, the tumor thickness was 2.5 centimeters, that is more than 2 centimeters, so it becomes a PT2. No LVI seen, predominantly nodular growth pattern, but focal infiltrative pattern was also seen. Margins were clear. Now, this was followed up by they did an axillary lymph node dissection for this patient, and 8 out of 11 lymph nodes turned out to be positive. Further treatment, they were considering adjuvant radiotherapy, but patient was subjected to immunotherapy and she has just completed one cycle of immunotherapy with nivolumab and currently on regular follow-up. So the diagnosis is quite straightforward here. It is a Merkel cell carcinoma. Now, Merkel cell carcinoma are rare, aggressive neuroendocrine carcinomas of the skin, first described in 1972 by Cyril Toker, where he called it as a trabecular carcinoma with carcinoid features. Now, later on, they found that this cells in this tumor had features which resemble Merkel cells, and that is how the name Merkel cell carcinoma came into being. This was followed by, there was a long gap here in the and around 2008, Patrick Moore and Yuan Chang discovered that this carcinoma is linked because they really didn't know where is it arising from. Okay, so this discovery was very significant, and they discovered that in majority of these Merkel cell carcinomas you do see expression or infection with Merkel cell polyoma virus. Yeah, so we were talking about Merkel cells, right? Why this tumor shows cells which resemble Merkel cells. Now, what are these Merkel cells? Merkel cells are seen in the basal layer of the skin and around hair follicles. They originate from the epidermal progenitors during embryonic development, and they play an important role in sensory system of the skin, mainly mechanofunction as mechanoreceptors. Let us remember this: ATOH1 or the atonal BHLH transcription factor 1 is the gene that is required for development of Merkel cells. Now remember this. Why? We will come to know later. Now, just like your Merkel cell carcinoma cells, these cells also express cytokeratins and neuroendocrine markers. But does the tumor actually arise from Merkel cells? Let's find out. A little bit about the epidemiology. Now, the incidence of Merkel cell carcinoma is rare, with rates as low as 0.69 per 1 lakh population in US and 1.6 per 1 lakh population in Queensland, that is Australia. Median age, yes, it's in the elderly age group. With, remember this, our patient was just 33 years old, okay, with only 12% of patients presenting under 60 years. Risk factors: ultraviolet radiation, immunosuppression. HIV patients could have other things, chronic inflammatory disorders like rheumatoid arthritis. Wherever there is some immunosuppression, it could be a risk factor for Merkel cell carcinoma. Similarly, arsenic exposure. Now, look at this. The 5-year overall survival rates for Merkel cell carcinoma is 51% if it is a localized disease, 35% if there is nodal involvement, and just 14% for metastatic disease. Now, they say this survival rate is even worse than that for melanoma. However, there has been certain newer treatment options that are now available for Merkel cell carcinoma. How do they present? Usually, what is described as the AEIOU or the bubble kind of mnemonic. So, usually asymptomatic, or they present with a rapidly increasing mass. Immunosuppression is often associated with it. Usually older patients, but in a small percentage of cases, it can occur in younger patients as well. And usually in the sun exposed or fair skinned people. Yeah, we said that okay, Merkel cell carcinoma is associated with Merkel cell polyomavirus infection, right? Let us know, do all Merkel cell carcinomas have this? No. So there are two distinct pathways by which you get Merkel cell carcinoma. One is the virus-associated Merkel cell carcinoma, or the MCCP, okay, which is caused by clonal integration of Merkel cell polyomavirus in the epidermal or the dermal cells or the perifollicular cells with persistent expression of viral T antigens. The second one is a non-viral Merkel cell carcinoma, also called as the MCCN, which is caused by UV-induced DNA damage leading to highly mutated genomes. Now, despite two different pathways, they ultimately culminate onto the same pathway, okay, and that is why, despite different origins, both forms present similarly. Both of them have present as a similar Merkel cell carcinoma. Now, molecular pathogenesis, very important here. There are two distinct pathways. One is the MCCP, which is associated with Merkel cell polyomavirus infection, and the other one, the which is ultraviolet exposure to ultraviolet radiation. Now, look at this. The MCCP, certain factors involving the cell cycle are inactivated by the viral antigens. Like this, the large T cell antigen, the viral large T cell antigen inactivates retinoblastoma gene. The small viral small T cell antigen inactivates P53, not directly, but by upregulation of MDM2. On the contrary, in MCCN, both RB1, because of the ultraviolet radiation, RB1 and TP53 are mutated. Okay, so basically, both of them having the same effect. There is MIC-L overexpression because of the ST EP400 complex, which brings about upregulation of activity of MIC-L. In the MCCN, that is the ultraviolet pathway, the MIC-L is amplified. Similarly, the ATOH, which I said was required for the differentiation or the maturation of Merkel cells, now this is attenuated by LSD. The LSD, which is as a byproduct of the viral infection, the LSD that is upregulated, which brings about attenuation of the ATOH1. Similarly, in the MCCN pathway or the ultraviolet pathway, certain chromatin factors which bring about inactivation or decreased activity of ATOH. So that means to say they are not changing or they are not maturing into mature Merkel cells. So this is the molecular pathogenesis that is occurring in Merkel cell carcinoma. Since there are two different pathways, and since some of them are not associated with viral infection, there are certain differences, like some of which I've already discussed. So etiology is the Merkel cell polyomavirus in the MCCP pathway, ultraviolet radiation in MCCN pathway. It is the viral infection associated Merkel cell carcinoma is more common, but Indian data suggests something else. Okay, so which we will come to later. So it depends on the geographic location where the patient is manifesting as Merkel cell carcinoma. Mutation burden is low here, whereas it is high because of the ultraviolet radiation-induced mutagenesis. P53, like I already mentioned, it is inactivated here, whereas it is mutated in the MCCN pathway. RB again is inactivated, whereas it is mutated in MCCN. MIC-L, because of this complex, the EP400 complex, there is upregulation of MIC-L, whereas it is amplified in the ultraviolet pathway. Now, what are the new antigens that are being expressed by the tumor cells? It is the viral, small, and T cell antigens. On the contrary, in the ultraviolet pathway, it is the mutational antigens. The mutation occurs because of which there is new antigens that are being expressed. Now, the MCCN pathway is more dangerous because it can result in additional mutations. But look at this. This is expressing new antigens, the viral antigens. This is mutational antigens that are expressed. Now, both of them show good response to immune checkpoint therapy. Now, this was what I wanted to highlight. Why you should remember Merkel cell carcinoma. This is one of the first cancers which have shown a very good response to the immunotherapy. Now, that is because of the antigenic neoantigens that are being expressed by these tumor cells. Yes, cell of origin. We still don't know what it is, but possibly in the ultraviolet pathway, it probably arises from the sun-exposed keratinocytes secondary to the ultraviolet-induced DNA damage. Whereas in case of the viral pathway, it is probably arises from the non-exposed cells, possibly from hair follicle progenitor cells. It is still not definitely for sure. Yes, this was what I was telling. Indian data. There was one article which was published in 2019, which in the microbial pathology journal, where they tested for the Merkel cell polyoma virus by immunohistochemistry and using PCR in 18 cases of Merkel cell carcinoma from Indian population. The specific antibodies that were used were CM2B4 and AB3, and PCR also was targeting the N terminus of the T antigen. Now look at the data that they have got. It was only IHC was positive in around 38% of the cases, while only 25% of the cases were positive both by IHC and PCR. That means to say you have more than 50% of the cases are not linked to the virus, the Merkel cell polyoma virus. Treatment, yes, wide local excision, and they say the clearance margin should be at least 1 to 2 centimeters. Sentinel lymph node biopsy definitely should be done to look for metastasis, because they are prone for metastasis. Radiotherapy in lymph node positive cases, they do that. But what is important? What is the new thing that has come up? It is the immune checkpoint inhibitors. So Merkel cell carcinoma gives a very good response to immune checkpoint inhibitors. Lastly, about staging. Now you have this based on the size of the tumor. Less than 2 centimeters is PT1, 2 to 5 centimeters is PT2. Our tumor fell in this category. PT3 will be more than 5 centimeters, and PT4 when it invades the adjacent bone, cartilage, etc. Regional lymph nodes also, there are certain differences here. Microscopic regional lymph node metastasis following dissection, when it is clinically occult, becomes N1A, and N1B, microscopic confirmation of clinically detected regional lymph node metastasis. This was what was seen in our case, because even clinically it was suspected. Almost 8 out of 11 lymph nodes showed metastatic deposits. Okay, that completes. So what is the take-home message here? Even though, okay, on morphology, the epidermis will be intact. You have the tumor, which is usually even though Merkel cell carcinoma sounds like a epithelial malignancy, so you expect that the overlying epithelium will be involved. No, here most of the times it is not involved. It is usually a dermal or a subcutaneous lesion. Yes, the MCCN, that is a non-viral associated Merkel cell carcinoma, can arise from another cutaneous malignancy like squamous cell carcinoma, even a melanoma. So always keep that in mind. There have been several reports where you found Merkel cell carcinoma coexisting with the squamous cell carcinoma of the skin. And the histomorphology is typical, just like small cell carcinoma elsewhere. It will have this typical stippled chromatin. Yeah, the differential diagnosis, which includes sarcomas, needs to be ruled out. What characteristic immunohistochemistry finding is the paranuclear or perinuclear dot-like positivity for cytokeratin 20, along with the synaptophysin or neuroendocrine markers. CD99 in our case showed some dot-like positivity for this thing. Of course, rule out the other differential diagnosis. Most importantly, rule out a metastasis from lung small cell carcinoma. Yes, that is it. Any doubts on the case?
Thank you, Dr. Vidya, for the detailed discussion on the case. I think spotted number 3 is pending. We'll come back to it later. Now we move on to the hematology cases. So next we are discussing long case number 3, which will be presented by Dr. Janvi from Rajrajeshwari Medical College, Bangalore. Dr. Janvi. Please switch on your audio. Please share your screen.
Open the PowerPoint, Janvi. Yes.
I can't hear you, Janvi. Are you talking already?
You're not audible.
Janvi, we'll get back to you with your once you set the audio right. Just stop sharing once. Shall we move to the next case? I'll just, Dr. Reshma, are you ready with your present to share? Dr. Reshma
Hello.
Shinde. Hi, Reshma. Is that
Am I
you?
audible now?
Yes, you're audible.
Okay. Okay, sir.
Dr. Sushma, ma'am, can we ask
Yes.
Dr. Reshma to present this?
Yes. So we
Hello.
have spotted number 3, which will be presented by Dr. Reshma from Yenapoya Medical College. Yes, you can start, Dr. Reshma.
Good afternoon, everyone. I am Dr. Reshma, first year postgraduate in Apoya Medical College, Mangalore. So the history provided was like 55-year-old male with right cervical lymph node enlargement. This is a partial effacement of lymph node, and this is a 4x magnification showing dilated sinuses. And this is 10x magnification showing different foci of marked dilatation of sinusoids. And this is a 20x showing polymorphous population of lymphocytes, plasma cells, and histiocytes, and many histiocytes showing emperipolysis. And this is also a 40x magnification where section shows marked dilatation of the sinuses, and these sinuses are occupied by lymphocytes, plasma cells, and numerous histiocytes. And this is another different foci of 40x, which showing marked dilatation of the sinuses with histiocytes, and few of the histiocytes showing emperipolysis. And this is another foci in 40x magnification where this histiocytes having large vesicular nucleus and abundant clear to lightly eosinophilic cytoplasm. So the findings are section study shows partial effacement of lymph node architecture, and there is a marked dilatation of the sinuses, and the sinuses are occupied by lymphocytes, plasma cells, and numerous histiocytes. And these histiocytes are having large vesicular nucleus and abundant clear to lightly eosinophilic cytoplasm. And few of these histiocytes exhibit emperipolysis. So mitosis are sparse, and there is no evidence of necrosis of granuloma. So my differentials are sinus histiocytosis, possibility of Rosai-Dorfman disease, and Langerhans cell histiocytosis. So in Rosai-Dorfman disease, the nuclear features are round to oval, vesicular nuclei, and sometimes sometimes lobulated with abundant pale and vacuolated cytoplasm. But in LCH, nuclei are folded, grooved, coffee bean appearance with moderate to pale eosinophilic cytoplasm. Well, in RDD, the architecture is marked sinusoidal expansion with distended sinus in a background of abundant plasma cells, lymphocytes, and neutrophils. But in LCH, there are sheets or clusters of Langerhans cells which may infiltrate interfollicular areas or paracortex in a background of numerous eosinophils, variable lymphocytes, and rarely plasma cells. So in the architecture, RDD shows emperipolysis, and in LCH, numerous Birbeck granules are seen. So the classic site of RDD is lymph node, which is often cervical, and LCH usually seen in bone, skin, lung, and pituitary. So there are different IHC markers to differentiate between RDD and LCH. whereas CD1A and CD27 are negative in RDD, but both are positive in LCH. And S100 is positive in both RDD and LCH, and CD68 and CD163 is positive in positive in RDD, but CD68 is positive in LCH, but CD163 can be negative or can be variable in LCH. So my final diagnosis will be Rosay-Dorfman disease, and these are my references. Thank you.
Thank you, Dr. Reshma. I request
Mr. Reshma,
Dr.
please stop sharing.
I request Dr. Swati Prabhu, Assistant Professor of Pathology, to discuss this case.
Good afternoon. Thank you, Dr. Reshma. Am I audible? Slide is visible.
Yes.
Okay. Yeah. So the DDs were described nicely. That is Rosette Hoffman with LCH by Dr. Reshma. So let us see what was there. Yes, I agree that was a lymph node which was partially effaced, and what was characteristic in this was there was little bit of pericapsular fibrosis along with dilatation of lot of his sinuses. Here there was a lot of sinus in this case compared to case 2. This had lot of sinus enlargement, and when we saw closely, they were all these histiocytes, plasma cells, and lymphocytes. So, and when we come to the high part, what we saw was all these histiocytes trying to engulf the inflammatory cells, and it is called emperipolysis because the as we see here, the structure of the lymphocytes, they are intact. It could be lymphocytes or plasma cell and whatever it is, but the structure will be intact. Whereas what happens in tingible body macrophages is that there is the debris of the cells that is present within the macrophage. So also one characteristic finding of this Rosay-Dorfman is this the nucleus of the sinus histiocytes, they will have this very prominent nucleoli. So compared to a normal or a reactive lymph node where this such prominence of nuclei will not be present. And these are all this slide shows lot of emperipolysis. Again, one more hyper image where histiocytes is engulfing the lymphocytes. So we did one IHC, that is S100, which was showing positivity, and here the cells which is showing negative is the engulfed lymphocytes. Okay, all the sinuses histiocytes were shown positive for S100, and they also showed positivity for cyclin D1. So coming to the differential diagnosis, okay, I agree the diagnosis was sinus histomassive lymphadenopathy, but also even the reactive non-specific sinus histiocytosis also will come into the DD in this case. But we have to put specific markers to prove that it is a benign process, that is Rosay-Dorfman disease. So this is a disease which is a benign disorder where there is lot of intracellular engulfment of lymphocytes by the histiocytes, also known as Rosay-Dorfman disease, as it was initially described by Rosay and Dorfman. The etiology is unknown, but however, some papers, literature suggest it could be an infectious process. Also, this case, actually, a patient had a history of travel to Kazakhstan where he said after he came from there, he developed all these lesions. So we were trying to rule out and if there was any infections that actually caused it, but that nothing is specific as such for Rosay-Dorfman disease. It can present in any age, but mean is 20 years. More common in males, most common again in cervical lymph nodes, but however, any extranodal site can be involved. This patient did have bone marrow involvement where there was PET, they did PET, and there was uptake in the bone lesion, there was uptake in the bone marrow. They may be associated with fever and night sweats, and most of the cases are self-limited. Then when you come to histopathology, we see there is effacement of follicles and characteristic dilatation of sinuses with emperipolysis. And there can be lipid-laden macrophages. Also, there can be some neutrophilic aggregates, and also we can also see infarct type of necrosis, which is rare, but we did find in this case that 4 lymph nodes were sent, out of which 2 were completely necrotic. And there were some neutrophilic aggregates also present in the node and other nodes. So IHC's monocyte macrophage marker like CD68, S100, cyclin D1 will be positive in this case. And when LCH comes in diagnosis, the most important IHC CD1A, which is negative in this case and positive in LCH. Also a characteristic feature of a Langerhans cell histiocytosis where the sinus histiocytes or the histiocytes will have that characteristic groove-like nucleus which will not be seen in Rosai-Dorfman disease. So the DDs will be again, first will be if there is an unexplained lymphadenopathy, say there is no tumor, we have to search for other causes of a reactive lymphadenopathy. Like for example, we had two cases, that is toxoplasma, and in this case that is Rosai-Dorfman. And S100. One more important thing is if it is a reactive lymph node, S100 will only be positive in few cells, whereas in Rosai-Dorfman disease, if in reactive lymph node, it will be S100 will be few cells, whereas in Rosai-Dorfman, all the cells, all the sinus histiocytes will be positive for S100. And LCH will be, in LCH you can find the characteristic histiocytes with the twisted nuclear grooves, which will be positive again for S100 or cyclin D1, but CD1A will be positive in this case, which is negative in Rosai-Dorfman. Also, sometimes Hodgkin lymphoma can come into a diagnosis when the RS cells like this, when a prominent nuclei is present. Of course, we have to rule out Hodgkin cells, and that characteristic feature like CD15 and 30 will help to rule out the diagnosis. So that will be the end of discussion. Any doubts?
Thank you, Dr. Shweta. I think Dr. Janvi is ready with her presentation. Dr. Janvi, just try unmuting once and see if you're audible.
Thank you, Dr. Swati. Now we move on to long case number 3. Dr. Janvi from Rajajeshwari Medical College, Bangalore.
Dr. Janvi, check your audio once.
Hello, sir. Am I audible?
Yes.
Okay. Good afternoon, everyone. I'm Dr. Jahnavi from Rajajeshwari Medical College and Hospital. I'll be discussing long case number 3, slides 12 and 13. Coming to the history, 54-year male with pancytopenia and massive splenomegaly. Slides given were 1 bone marrow aspirate and 1 bone marrow biopsy. So based on the history, we can think of some chronic marrow disorders, lymphoid or myeloid neoplasms, secondary to the splenic sequestration. So this is the aspirate showing normal cellularity. And coming to the bone marrow interpretation, aspiration is normocellular with few marrow fragments. Erythroid series and myeloid series are decreased. Megakaryocytes reduced in number with normal morphology. And coming to the lymphoid series, abundant with few abnormal forms like hairy cells. So these are the hairy cells, which are small to medium lymphoid cells with oval or reniform nuclei with fine chromatin. Cytoplasm is abundant, pale blue with irregular hair-like cytoplasmic projections, hence the name hairy cells. And one more slide is bone marrow biopsy, where the marrow is normocellular with focal hypercellular areas and fibrocollagenous areas. There's a diffuse and interstitial infiltrate of monotonous lymphoid cells. These cells have oval to reniform nuclei, condensed chromatin, and moderate amounts of pale cytoplasm, producing a classical fried egg appearance. And normal trilineage hematopoiesis is suppressed. So if we see here, the arrow focused on a hypercellular area, and this is a fried egg appearance of the cell with clear halo around the nuclei. So coming to the interpretation, the Triffin biopsy shows a diffuse interstitial lymphoid infiltrate with fried egg morphology and marrow fibrosis, which along with the clinical history, that is a 54-year-old male with pancytopenia and splenomegaly, and aspirate findings, those are hairy cells, a diagnostic of hairy cell leukemia. Summary, 54-year with massive splenomegaly who has pancytopenia on peripheral smear, and aspirate shows normocellular marrow with reduced erythroid, myeloid, and megakaryocyte elements with abundant lymphocytes and hairy cells. bone marrow aspirate showing diffuse interstitial lymphoid infiltrate with fried egg morphology and marrow fibrosis. I would the most probable diagnosis for this favors to the hairy cell leukemia. Suggested workup with flow cytometry and molecular genetic analysis for the confirmation. Molecular genetics involve BRAF V600E mutation, which is a disease-defining mutation here, and IHC where CD19 and 20 will be positive. Probable DDs could be splenic B cell lymphoma, where it lacks BRAF mutation, and splenic marginal zone lymphoma, where we can see heterogeneous small to medium sized lymphocytes with and villous lymphocytes can also be seen. Thank you.
Thank you, Dr. Janvi. Now I call upon Dr. Sindhura Lakshmi, Associate Professor of Pathology, KMC, to discuss this case.
Okay, am I audible, ma'am?
Yes.
Okay. So, thank you, Dr. Janvi, for a nice description of the case. So, we are discussing long case number 3. So, as you rightly pointed out, the morphology was very typical. It is indeed hairy cell leukemia. Now, hairy cell leukemia accounts for about 2 to 3% of all the leukemias, with an annual incidence ranging from 2.9 to 4.57 cases per million. Men are more affected than women, close to 4:1 to 5:1 ratio, with a median age of diagnosis at 55 years. Now, when we think of HCL, there are several things one should consider. One is definitely morphology. Patients will present with pancytopenia with massive spleen, like the classic history that was given. Usually, there will be leukopenia with monocytopenia. There may or may not be anemia and thrombocytopenia. The blood smear morphology is very, very typical, as you saw in this case, hairy lymphocytes. In biochemistry, there will be increased beta-2 microglobulin, increased LDH, and also IL-2 receptor. So these are prognostic markers. When we do flow on the bone marrow aspirate, or if you can manage on the peripheral blood, there will be CD123, CD103, and CD25 positivity, along with CD11C. Now, immunohistochemistry-wise, the bone marrow is generally, bone marrow biopsy is not always indicated. Aspirate usually gives the diagnosis unless the marrow is fibrosed. If bone marrow biopsy is done, usually it is done in complex cases and also when you want to do immunohistochemistry. So in immunohistochemistry, either you can also do TRAP, tartrate resistant acid phosphatase testing by cytochemistry, or immunohistochemistry by annexin A1. So what makes it complex? Now we saw that it was a fairly straightforward case. You saw hairy cells and you know that it is hairy cell leukemia. So main thing here is you must consider 3 different things. As Dr. Janvi pointed out, you have to consider other causes of other lymphomas which present with pancytopenia and also hairy cells or cells with villous projections. So hairy cell leukemia by and large is defined by BRAF V600E mutation, although some 10% of the cases may not have mutation at V600E location. There may be another location which shows the mutation. We'll come to that. Or there may be mutations in MAP2 kinase pathway. Now, this is the picture from the slide. If you can, yeah. So you can see this is the normal lymphoid cell, okay, for comparison, and these two are the hairy cells. Now, when you describe hairy cells, you should consider where are the hairy projections. You know that they are hairy cells, but there are different types of hairy cells. Now, these hairy cells have circumferential projections. You see, they're all over the surface. There nice projections, and they are not polar. They are not located at one end or the other. They are circumferentially located. Now remember this point when we come to the differential diagnosis, we'll discuss this further. Okay. So characteristic hairy appearance is because of the BRAF mutation. Okay, so because of the BRAF mutation, there is impaired activity in the cytoskeleton, particularly affecting the actin in the cell membrane. So these hair-like outgrowths help the abnormal cells with their interaction with other cells and ligands. So tumor microenvironment is mainly influenced by these hairy projections. So there may be several risk factors. It is not very uncommon in this part of the world, mainly because we're in agriculture-based countries like India, mainly because of exposure to pesticides, petroleum derivatives, diesel, ionizing radiations, etc. There may be occasional familial cases that are seen in the literature. Tobacco appears to be protective for HCl for reasons unknown. Now, clinically, there is a triad: splenomegaly, leukopenia, and monocytopenia. However, when you get peripheral blood for routine cell counting, you may see monocytosis on the cell counter data. So we'll come to that. Now, as I said, first we'll do the morphology and then come back to the scatterogram in cell counters. So three different DDs. One is HCl variant, or now known as splenic B-cell lymphoma with prominent nucleoli. Second DD is SDRPL, that is splenic diffuse red pulp lymphoma. And the last one is splenic marginal zone lymphoma. Now, how do we rule out each of these? We'll come to that. So one is the automated cell counter scatter and also morphology. So if you look at this, you can see that this is the healthy adult. You see the lymphocytes and the monocytes in green here and the neutrophils in light blue. Whereas here you can see that there is a dual peak over here and double population in the monocyte region. This is the reason that you will see a spurious monocytosis on cell counter report. So this is a normal monocyte, normal lymphocyte. You see hairy cells over here, circumferential hairy projections over here in the HCl, whereas polar projections in SMZL, that is marginal zone lymphoma, will also have villous projections, but it will be polar as opposed to circumferential hairy projections in HCl. Now, on the histogram, there may be an abnormal monocyte cluster spreading over the lymphocyte zone, or there may be a lymphocyte double cluster, which was indicated by these two arrows, or there may be a complete lack of monocyte cluster, which is supposed to be here, which may be absent in case of HCl. So morphologically, how do we differentiate between the closed differential diagnosis? One is long, fine, well-defined circumferential villi. The nuclei are, as Dr. Janvi described, they may be reniform. You may have found cells just like this in the slide that was given. The chromatin is mature and homogeneous, and it is not at all clumped. There may not be any nucleolus. Very unusual to have a nucleolus in hairy cell leukemia. In contrast, in hairy cell variant, usually the patients present with leukocytosis rather than leukopenia. There may be circumferential the hairy projections, but they are not very nicely defined as you would see in hairy cell leukemia. They will be shaggy and very cells may appear as though they are degenerating cells, like you would see in CLL. They may be appearing very fragile, having very, very fragile cytoplasm. Very, very important thing here is the nucleolus. You see the nucleolus, the reason the nucleolus is important here is that is the one which is giving it name. This splenic B-cell lymphoma with prominent nucleoli. That name is derived because of this prominent nucleolus. It is so prominent that the nucleolar membrane is like like you have taken a pencil and drawn the nucleolar membrane around it. It will be that prominent. Whereas SDRPL, the splenic diffuse red pulp lymphoma, there may be the circulating the abnormal cells may not be high, but there may be increased cells in the bone marrow. Large, broad-based bipolar or multipolar hairy projections here. The nucleus is usually round without any indentations as opposed to HCl. The chromatin is condensed, and also there may not be any nucleolus. Whereas SMZL is much more common compared to all other three variants here. There will be polar projection, polar villus projections. Earlier name for SMZL was splenic villus B-cell lymphoma. So it used to be called as SLVL, splenic large villus lymphoma. So you should always note the type of villus projections and not jump to the diagnosis that just because you saw hairy projections, it is hairy cell leukemia. Now on flow cytometry, the usual B cell markers are very, very brightly expressed. So compared to CLL, suppose, for example, in CLL, you will see dim expression of CD19 and 20. There may be 200 expression in CLL also, but the bright expression is seen in HCL, the hairy cell leukemia. It is typically CD5, CD10 negative. The CD23 is usually absent. If it is present, you must always rule out mantle cell lymphoma, even if CD5 is negative, because there are reports with CD5 negative mantle cell lymphoma, and also there may be CD5 positive HCL also. So whenever you see CD23, always rule out mantle cell lymphoma. Classically, the hairy cell leukemia will be positive for CD11C, CD103, CD123, and CD25. These four markers are important because it can be used for an immunophenotypic scoring. If more than three or more of these markers are positive, it is invariably hairy cell leukemia. CD25 may be negative in case of HCL variant. In such cases, you must consider, if the CD25 is negative, in such cases, you must consider hairy cell leukemia variant, particularly if the total count is normal or increased in the peripheral blood. Now, these flow plots are pertaining to the case that was given. You can see that so I will not go to the basics for want of time. So usually CD45 bright area is over here where you see normal lymphoid cells, and above this is the area for monocytes, and these are the granulocytes. Because these cells have a lot of cytoplasm and have hairy projections, they have higher site scatter encroaching upon the monocytic region, just as you saw in the automated cell counter scatter plot. And as I mentioned earlier, the CD19 and 20 are very brightly expressed as opposed to CLL and other B-cell lymphomas. This particular case was surface immunoglobulin lambda restricted. CD123 was nicely positive. CD103 was heterogeneous moderate positivity here. CD200 is quite bright. These are the T cells which are CD5 positive but 200 negative. You compare your expression with the T cells as internal control. And CD25 here is also positive. You may see that it is only this much, but it is plotted with CD19, which is showing bright expression. That is why you think that it may be dim, but significant percentage of the cells were CD25 positive. In this particular case, CD23 was also positive, which you must keep in mind that you have to rule out the mantle cell lymphoma. How do you do that? You first do cyclin D1 on bone marrow biopsy. If that is negative, then you go on to do CCND1 and also annexin to rule out mantle cell lymphoma. It has to be completely ruled out because the treatment is different. Now, the other markers such as 79B and 10 were also negative. CD38 may come positive in some cases, which shows poor prognosis. Now, 11C we did not do. In this is a case from literature. In this case, you can see the expression of CD23 here as well. This is CD11C in this case. Now, bone marrow trephine is generally not indicated unless you are looking at a complicated case. You don't know whether it is hairy cell leukemia variant or SDRPL or SMZL. Then you do biopsy and do annexin A1. This was the slide that was given to you, and you can see that all cells have a lot of cytoplasm. That's the reason you are seeing tail areas in between. And this is a typical slide appearance as described by Dr. Janvi. Now, BRAF V600E mutation is central for the diagnosis of HCL. So, in this, this occurs at exon 15 at position 1799, where thymine and adenine are exchanged, leading to valine being replaced by glutamic acid. So, this mutated protein in turn activates the MAP kinase pathway, leading to downstream effects. Now, absence of BRAF mutation can be seen in 10% of cases. In such cases, exon 11 must be checked. Mutation in exon 11 must be checked because in these 10% of cases, the exon 11 may be mutated. You can't just do BRAF V600E by Sanger sequencing and say that if it is negative, it is not HCL. If all other clinical features, morphology, flow, everything is corroborating, you must do exon 11 mutation as well. BRAF mutation is very, very important here, mainly from therapeutic point of view. There are three different types of categories based on the BRAF mutation. Class 1 with high kinase activity, class 2 with high or intermediate kinase activity, and class 3 where kinase impaired activity, which means if you are giving kinase inhibitors, class 3 mutation, if the patients with class 3 mutations will not benefit. So it is crucial to identify mutation categories and also important to identify the non-BRAF V600E mutations such as exon 11 mutation, because BRAF inhibitors can only be used when there is BRAF V600E mutation. Now, what are the other tumors which are associated with BRAF mutation? It can also be seen in melanoma, papillary thyroid carcinoma, colorectal carcinoma, carcinoma ovary, breast, lung, cholangiocarcinoma, glioblastoma, and other low-grade gliomas. Adam-Chester disease, the LCH, which we discussed in the previous case, GIST, and also in the non-papillary RCC. So don't think that BRAF is only seen in HCL. BRAF V600E typically is seen in hair cell leukemia, but there are other BRAF mutations which can cause cancers elsewhere as well. Now, what are the poor prognostic factors? Splenomegaly more than 3 centimeters. Hyperleukocytosis. Generally, these patients present with leukopenia, but if there is, sorry, the number is missing here. The more than a million per liter, more than 100,000 per microliter. It's actually leukocytosis, hairy cells in the peripheral blood, high beta 2 microglobulin, increased LDH, CD38 positivity. These are all poor prognostic factors. Along with that, unmutated IGHV is also portends poor prognosis. TP53 mutations are rarely found in HCL, but if it is there, it carries dismal prognosis. TP53 mutations are generally seen in HCL variant. Now, this is the diagnostic algorithm one must follow. If the WBC count is high and there is no monocytopenia, the patients can present with high WBC count or low WBC count, with or without monocytopenia. Now, the first thing you have to look at is the morphology. So, if the morphology shows villous lymphoid cells, if the cells have prominent nucleolus, then one diagnosis is HCL variant. After you exclude mantle cell lymphoma or CLL related, the PLL, earlier what we used to call as PLL. If now CD5 is positive, then do 1114, look for 1114 translocation for MCL or do SOX11 and CCND1 to rule out mantle cell lymphoma. At the same time, do flow cytometry, check if CD11C is bright. if CD11C is bright. Then look for BRAF, MAP2 kinase, and IGHV. So it could be splenic B-cell lymphoma with prominent nucleoli or HCL variant. Now, if 11C is dim or just moderate or only in subset or negative, again look for BRAF, MAP kinase 2, and IGHV, and the cytogenetic testing for splenic B-cell lymphoma prominent nucleoli. Now, if there is no prominent nucleolus, then your HCL comes into strong suspicion. Less than 20% villus cells and HCL score is less than 3, then look for NOTCH2 and KLF2, which would diagnose SMZL. And also, if on flow, you can also do CD180 and CD200. If the CD180 is brighter, then it is more likely to be SMZL than HCL. Now, if more than 20% villus cells are present in circulation, in such case, and HCL score is low, but 11C is bright, and CD180 by CD200, the mean fluorescent intensity is tilting more towards CD200, that is brighter CD200, then it is more likely to be SDRPL, splenic diffuse red pulp lymphoma. If HCL score is more than 3 and CD25 is positive and BRAF V600E is mutated, then the diagnosis is HCL. And these cases are usually with leukopenia and monocytopenia, but don't disregard HCL diagnosis even if you see leukocytosis and no monocytopenia. So, do you have any doubts? Are there any doubts?
Thank you, Dr. Sindura. Now we quickly move on to the next hematology case, long case number 4, which will be presented by Dr. Pallavi from KVJ Medical College, Surya. Dr. Pallavi, are you there?
Yes. Yes, ma'am.
Yeah. Please share your PPT.
Yes, ma'am. Is it visible, ma'am?
Yes. You can start.
Yeah, okay. Good afternoon, everyone. So I'm Dr. Pallavi. I'll be presenting long case number 4. So history given to us was 8-year-old male with severe anemia and leukocytosis, skin rash and hepatomegaly was present. So going further for microscopy, we received bone marrow aspirate slide. It was hypercellular, and we can see so many blast cells were present, with few of the blasts were having or rods. So coming to interpretation, cellularity, so bone marrow aspirate smear studied were hypercellular with adequate cell trails. ME ratio was increased. Erythroid series was decreased in number, showing normoblastic and megaloblastic maturation. Myeloid series increased in number and shows suppression of myeloid maturation, and myeloblast constitutes more than 20% of blasts, showing high NC ratio, 1 to 2 prominent nuclei. Cytoplasm shows all rods. Lymphoid series was reduced in number and normal in morphology. Megakaryocytic series, megakaryocytes were suppressed and there was no storage cells or granuloma seen in the smear study. So according to bone marrow aspiration, we diagnosed it as acute myeloid leukemia, M2. Then we were provided with cytochemistry stains of myeloperoxidase stain and Sudan black P, which were showing positivity. So MPO stain highlights cytoplasmic granular positivity in myeloblasts and granulocytic precursors, and Sudan black P stains highlight cytoplasmic granular positivity in myeloblasts and granulocytic cells. Then we were provided with bone marrow biopsy. The length of bone marrow core biopsy was 2 cm and number of bony trabeculae was 10. So on the microscopy of bone marrow biopsy, it was showing erythroid series are decreased in number and show normoblastic to megaloblastic maturation. Myeloid series increase in number, comprising of myeloblasts having high NC ratio, 1 to 2 prominent nuclei, and cytoplasm shows all rods. Megakaryocytes were appeared to be decreased in number, and there was no evidence of granuloma or storage disease. So impression according to bone marrow biopsy was made as acute myeloid leukemia M2. On microscopy, we can see so many blast cells were present. So summarizing the case, the patient was 80-year-old with history of severe anemia and leukocytosis. Skin rash and hepatomegaly was present. Leishman stain bone marrow aspiration slides were hypercellular. There were more than 20% of the blast cells. Few of the blast cells were showing R rods and mature neutrophils were seen. MPO and SPP were stain positive, and bone marrow was showing much of myeloid blasts. So diagnosis made was acute myeloid leukemia M2. Coming to the discussion part, so 10% of the AML cases are M2 and 5% of the childhood leukemias. It occurs at any age, and mostly 20% are seen in below 25 years of age, and 40% are seen in 60 years plus patients. It presents with anemia, thrombocytopenia, neutropenia, variable number of blasts in peripheral blood, and it have a variable prognosis. So criteria for diagnosis is 20% of more than 20% of non-erythroid cells in the peripheral blood or bone marrow smears will be myeloblasts. Monocytic precursor should be less than 20% in the bone marrow, and granulocytes are more than 10% of the cells. On enzyme cytochemistry, more of the blast cells are positive for MPO and Sudan black B and chloroacetate esterase. Usually, usually the bone marrow will be hypercellular marrow and full range of myeloid maturation through maturing neutrophils, often with abnormal segmentation and more than 10% of the bone marrow cells with variable degree of dysplasia. Or rods in 70% of the blasts will be seen. Myeloblasts with or without azurophilic granules will be seen. Often increase eosinophilic precursors without cytological and cytochemical abnormalities of INV16, P13.1, and Q22. So this is FAB classification. According to FAB classification, M0 is AML with minimal differentiation, M1 AML with without maturation, M2 is AML with maturation, M3 is acute promyelocytic leukemia, M4 is acute myelomonocytic leukemia, M5 is acute monoblastic and monocytic leukemia, M6 is pure erythroid leukemia, and M7 is acute megakaryocytic leukemia. So WHO classification is having broad headings under AML with defining genetic abnormalities, AML with myelodysplasia related changes, therapy related myeloid neoplasm, AML not otherwise specified, myeloid sarcoma, and mixed phenotype acute leukemia. So positive stains for AML M2 mostly is CD34 and HLA-DR, and negative stains are usually CD14, CD36, CD41, CD61, CD64, and glycophorin A. So these were my references. Thank you.
Thank you, Dr. Pallavi. Now I again call upon Dr. Sindhura Lakshmi to discuss this case.
Is my slide visible, ma'am?
Yes.
Okay. Thank you, Dr. Pallavi, for describing the case. So we'll just go one by one. So as you rightly pointed out, this is indeed acute myeloid leukemia. Now, I'll just briefly give an overview of laboratory diagnosis, approach to laboratory diagnosis for AML. First and foremost, after history and physical findings, we would look at CBC with peripheral smear examination. We do bone marrow examination for morphology and cytochemistry. We do immunophenotyping either on peripheral blood or on bone marrow aspirate. Then cytogenetic testing, including conventional karyotyping and molecular testing to complete the diagnostic process. So now it was discussed, the FAB classification was discussed, although FAB is now like really really old. I just want to highlight things here. Remember, there are close differential diagnosis between M2 and M4. Particularly, if you're not doing differential count on the bone marrow aspirate, you're more likely to misclassify a myelomonocytic leukemia into an M2, AML M2, which is AML with partial differentiation. So it is very, very important for anybody who is reporting bone marrow aspirate to do a nucleated cell differential count. It is a must. Okay, so if without the nucleated cell differential count, you cannot really classify AMLs into different categories, even by FAB classification. So earlier it used to be there were two, three different kinds of count people used to do. Even here you can see that there is NEC. NEC means non-erythroid cell count. NEC over here. Okay, and there is also ANC, that is all nucleated cell count. So now uniformly the guidelines say that you must do all nucleated cell count, including the erythroids. So all the current classification is based on all nucleated cell count. And you must count at least 500 nucleated cells, excluding megakaryocytes and mast cells, and also the supporting cells in the bone marrow to arrive at a correct differential diagnosis in the bone marrow. Okay, so remember this point, and we'll go further and see why this point is worth considering. Now, this is the classification given by WHO HEME 5. Okay, so this is for the benefit of all the postgraduate students. See, I understand it is hard to keep up with all the new classifications that keep on coming every 5 years or so, but you must consider the most recent classification when you are describing a case or giving a diagnosis. Even in your future practice, you must always go by the most recent evidence. Okay, the classification which was described earlier is 2017 classification, which you had given, Dr. Pallavi. It is from 2017. Okay, so 2017 is now superseded by 2022 edition, that is WHO HEME 5. There is another classification called International Consensus Classification given by another group. Either of them you can follow, or both you can follow when you're reporting, but classifying the disease based on an older classification when a newer one is available is not recommended. Now, in WHO HEME 5, if you suppose not all of us have access to cytogenetic testing or molecular testing, but we still need to give some working diagnosis to our patients. It's our moral right, moral responsibility. So how do we define AMS by differentiation? It is AML with microdifferentiation, AML without maturation, AML with maturation, acute eosinophilic leukemia, acute myelomonocytic leukemia, acute erythroid leukemia, and acute primitive megakaryocytic leukemia. All other subclasses, say for example, acute promyelocytic leukemia, and other subclasses like acute monoblastic leukemia and whatever were there in the FAB classification, they are all found to have specific genetic abnormalities and will therefore be classified under specific genetic abnormalities only. Okay, so if you are defining your diagnosis of AML by cell differentiation alone, then you must use these terms. Okay, so you can mention FAB classification if you are keen on that, but even then, make sure that you have done all nucleated cell count and not non-erythroid cell count, which will alter your differential percentage of blasts and thereby misclassifying the AML. Okay, so now this is how the cell scatter would look like. Now, what is this? This is a triangular plot. This is the cell counter, the automated cell counter scatter plot. Now, this triangular plot is how you would see in acute promyelocytic leukemia. These two are from a leukopenic sample, whereas this is a sample of acute lymphoblastic leukemia. You can see that the increased cluster size of the lymphoid cells, whereas this is acute myeloid leukemia, you can see that the myeloid area has completely increased. And this is the acute myelomonocytic leukemia, where the monocytic area is merged with the granulocytic area. See, why should you remember the scatter plots first? I always want students to look at the automated cell counter scatter plots and histograms first, because by and large you are the first of the people who would be seeing anything related to leukemia for a particular patient. So if you miss on the cell counter data, you will misdiagnose on the morphology. Then a lot of treatment delays can occur, and sometimes it may be life-threatening, particularly in cases of APM. So this is a picture from the case which I have taken directly from the slide. Now, you have counted more than 20% myeloid. You said a lot of blasts are there. Yes, I agree. But you must also consider there are blast equivalents also in the picture, okay, in the slide. Now, this particular cell is a myeloid blast. This is a myeloid blast, right? Is this cell different from this cell? Yes, right? This is a different looking cell, but of course, this is also a blast. Looks like a blast, but it is not a blast like this. This is a blast equivalent. This is a monoblast. See, large cell, abundant cytoplasm, very open chromatin, prominent nucleoli. This is a monoblast. This is also similar to this. This is also a monoblast. This is also a monoblast. Well, these two are also looking abnormal, but they don't look like this cell or this cell. So these are, you can see the deep invagination over here. There is a indentation of the nucleus, open chromatin, occasional inconspicuous nucleolus. This is a pro-mono. These two are pro-monocytes. Okay, so you have myeloblast, you have monoblast, you also have pro-monocytes. So in this, if you do a non-nucleated cell count, you will see almost about 20-25% of myeloblast, but combined monoblast and promonocyte would be more than almost nearly about 80%. Okay, so this is an example of acute myelomonocytic leukemia. So there are other hints also. You can see this cell. What is this cell? This is a plasma cell. Okay, this is an erythroid cell. This is an erythroid cell. This is a plasma cell. Usually in myelomonocytic leukemias, if you go by FAB M4 and above, you may see plasma cells lurking in the background. You can identify them and clearly, that gives you a hint. Second thing you must consider is, just because you see OR rods in the myeloid blast, don't jump that it is just AML or just AM2. Okay, even anything above your FAB M2 can show OR rods, particularly, not in erythroid and megakaryoblast, but all others can show OR rods. So just because you see OR rods, it does not mean that it is only AML M2. It can be others also. So this is a picture from literature that I'm showing you. Here is the rod for you. Okay, these two are lymphoblasts. Just to show you an example. And here is the promyelocyte. Again, this is the hypergranular variant, and this is a hypogranular variant of promyelocytes. Here you can see the case that we just discussed, myelomonocytic leukemia. Here you can see the erythroid leukemia. Over here, the cytoplasmic vacuolations are present. Dyspoiesis over here, a lot of dyspoiesis in the background, and the myeloid blast also. And here you can see megakaryoblast blast with cytoplasmic projections. Okay, large blast with cytoplasmic projections. So this is an example of acute megakaryoblast leukemia. Now, how does cytochemistry help? Particularly, as you saw, MPO would help in identifying myeloid blasts. This is an example of SBB here, MPO here, and this is an example of SBB. Remember, SBB can also show positivity in T lymphoblasts, T ALS also. So, if you are given a choice, always choose MPO for the diagnosis of myeloblast than SBB. But SBB is useful in stored samples. Stored unstained smears can be stained with SBB because myeloperoxidase depends on the enzyme activity. In stored samples, the enzyme activity may go down and you may get false negative results. This is an example of PAS, block positivity in TALL. This is an example of the NSE, non-specific esterase, particularly useful in monocytic leukemias and monoblastic leukemias. What is this? This is Pearl stain. This is PAS stain again in erythroids, highlighting the dyspoetic erythroid cells. Now coming to immunophenotyping. So now immunophenotyping can be done by IHC or by flow cytometry. Flow cytometry is by far more, it's faster and cheaper compared to IHC. So I will not go into the details of each of the subtypes. This is the reference articles. This is not my slide. I've taken from an article. For the want of time, I will move forward. This is the immunophenotype of this particular case that was given. You can see that this is the progenitor region. Okay, these are the granulocytes, and as we discussed in the previous case, this is the monocyte region, and these are the lymphoid cells. So there is an expansion in the progenitor region. There are blasts, and there are also something abnormal with the monocytes as well. And we were expecting that looking at the morphology. Now, although MPO was reported as positive by Dr. Pallavi earlier, if you go back to the slide and see carefully, I don't have the pictures here with me. There is a significant number of cells in the background which are MPO negative. So what are those cells? You should also consider the ones which are negative, right? The smear was full of blasts, but only about maybe 30% were actually MPO positive, while the rest of them were negative. That alone should alert you to look for blast equivalents which are negative for MPO. Okay, so even in flow, there are only about 10 to 12% of the blasts were actually MPO positive. The background green population is granulocytes for internal control. There are a small subset also showed CD7 positivity. CD33 was nicely positive. The black population over here is coming from the monocyte region. Here you can see HLA-DR overexpression and also CD13 and 33 expression. Can you appreciate the differences between the expression of monocytic lineage blasts compared to the myeloid blasts? The monocytic lineage blasts are 33 brighter, whereas the myeloid lineage myeloblasts are 33 dimmer compared to the monocytic lineage blasts. Okay, so they were also positive for the blasts of monocytic differentiation were also positive for CD14, CD64, and they were negative for CD117. They were positive for CD36. Now, as per the lineage assignment, at least two of the monocytic lineage markers should be positive to call an AML with AML as AML with monocytic differentiation. Here we have all the three markers which are positive for positive. So this was the case of AML with monocytic differentiation. So this is myelomonocytic. You see the red population that is 64 dim, whereas black population which is 64 bright. Same goes here. 36 is nicely positive in the blast equivalent, whereas in the myeloid blast, the 36 is negative. Same goes for CD14. So there are two different population. One is myeloblast, another is blast of monocytic differentiation. So, okay. So since you pointed out OR rods, I'm just showing you these are slender OR rods. Can you guess what translocation would we see here? We would see translocation 821. So typically on flow, you will see CD19 expression along with other myeloid lineage markers being present. This should not be misclassified as mixed phenotypic leukemia because CD19 dim expression is known in translocation 821 AML. Now, what is this? These are the promonocytes which we saw earlier. You can see the delicate infolding of the nuclei over here. There may be some immature eosinophils. You can see eosinophilic granules. This is a mature eosinophil over here. And you can see eosinophils with basophilic granules. These are called eobasophils, typically seen in inversion 16 AMLs. So myelomonocytic leukemias can have translocation 821. They can have inversion 16, or they may sometimes have translocation 69, in which case you can see the degranulated dyspoetic basophils in the background. You can see the band cells, blasts over here, large and small blasts. Now, AML with NPM1 mutation with FLT3-ITD can show cup-like nuclear morphology in the blasts, and they may show 34 negativity. 34 negativity. Sometimes they are close differential diagnosis for acute promyelocytic leukemia. Now, I will not go into this table in detail. This is also taken from a journal which I have mentioned here, the previous one. So a lot of immunophenotypic characteristics can alert you for genetic alterations. You must be vigilant when you are counting the nucleated cells. It is very, very important that you do an absolute all nucleated cell, the differential count of all nucleated cells to arrive at the correct classification. In this era of genetic testing, it may not be your morphological diagnosis may not really make a difference to the patient unless it is specific subtypes like APML or acute megakaryoblast leukemia. But as pathologists, we should always strive hard to keep our morphology definitive, because morphology stands even if somebody discovers new mutations, new classification systems, as evidenced by FAB classification, which is entirely based on morphology. And for years, for decades, we have been following that because the morphology holds true. So, with that, I end my discussion here. If there are any doubts, please do ask.
Thank you, Dr. Sindhura, for the detailed discussion. I think we are running out of time. So coming to the last case for today's session, long case number 5. I think the PG who was supposed to present the case will not be available to present it. So I will directly go to the discussion. Okay, is my slide visible to everyone? Okay, so this was... yes, it is visible, right, ma'am?
Yes, yes.
Okay. So this was the last case, a 20-year-old female, episodes of jaundice for last 6 years, passing of intermittent dark color urine, and on examination, patient had pallor, icterus, and spleen palpable 5 centimeters below the lower costal margin. So left costal margin. Okay, so looking at the history, I think the PGs who are attending the session, you can all type what does the history suggest. I'm not able to see the chat session, so I will directly move to the next. So there is a triad of anemia, jaundice, and splenomegaly in this patient. So what does it indicate? It indicates hemolytic anemia. So when we talk about hemolytic anemia, it is important to know the differences between extravascular hemolysis and intravascular hemolysis. So the triad remains the same for both extra and intravascular hemolysis, but in intravascular hemolysis, along with other features, you also see hemoglobinemia, hemoglobinuria, and hemosideриnuria. So in this patient, this is the peripheral smear. So it is a very clear-cut picture. So you can see there are a lot of spherocytes, RBCs, which are very dense. They don't have the central pallor and they are smaller than the surrounding RBCs. So there is increased number of spherocytes in the smear and there is polychromasia. So you can see there are large polychromatophils. So this is a higher magnification showing the spherocytes. So there are two basic differential diagnosis in this case, hereditary spherocytosis and autoimmune hemolytic anemia. But looking at the age of the patient, young age, a very long history, 6 years history is given, and there is on and off jaundice, episodes of jaundice in this patient. So what will be the most probable diagnosis? It will be hereditary spherocytosis. And another important feature which differentiates hereditary spherocytosis from autoimmune hemolytic anemia is that the population of spherocytes or the spherocytic population that you see, they are very uniform in size and shape. Whereas in autoimmune hemolytic anemia, you will see spherocytes of varied sizes, but in hereditary, they are usually very uniform. Okay, so coming directly to lab diagnosis. So these features are common for all hemolytic anemias: decrease in hemoglobin, increase in reticulocyte count. But an important feature of hereditary spherocytosis is increased MCHC. So what other test can you do in this patient is osmotic fragility test, which is done in most of the centers. So red blood cells are placed in increasingly serial dilution of saline, so which causes water to move into the cells, and this will cause swelling of the RBCs. And it basically measures the resistance of the RBCs to rupture, which will be increased in conditions like hereditary spherocytosis. So this is how it is done. So you can see this is a normal control where the hemolysis starts later, whereas in hereditary spherocytosis, it will start early. And this is the graphic representation where we measure the optical density of the solution and we plot the graph. So in hereditary spherocytosis, the graph will move towards the right. Now, and a very advancement in the diagnosis of hereditary spherocytosis is flow cytometry, because osmotic fragility, at least 15 to 20% of cases can come as false negative. So EMA binding is an important breakthrough in the diagnosis of hereditary spherocytosis, which we are doing in our lab. So basically, a fluorescent dye, eosin 5 melamide, is allowed to bind to band 3 protein on red blood cells. So in hereditary spherocytosis, where there is defect in band 3 and other membrane proteins, there will be reduced binding of this fluorescent dye to the RBCs. So this is how we interpret the test. So we run 5 controls and we measure the mean fluorescent intensity. So you can see in the 5 controls, the mean fluorescent intensity is in the range of 18,000 to 20,000. Whereas in the patient, the mean fluorescent intensity is only 12,800. So it is significantly reduced in the patient. So how do we calculate the ratio? So there are two methods. One is you have to calculate the patient to control ratio. So you take the mean of all the 5 controls and you divide the patient's MFI by the mean MFI of the controls, and the cutoff for hereditary spherocytosis is less than 0.8. Also, we have to calculate the percentage of fluorescence reduction by using this formula, that is MFI control minus MFI of the patient divided by MFI control multiplied by 100. And more than 20% reduction suggests hereditary spherocytosis, whereas less than 15% reduction excludes hereditary spherocytosis. So of course, there are many other tests, but most of them have found to be less sensitive. What is most important is by actually detecting the abnormal proteins by either doing a gel electrophoresis like page, or you can do a PCR for detection of the mutations. I'm not going into the details of hereditary spherocytosis because you all can read it from the book. So this is the final diagnosis of all the cases, 5 spotters and the 5 long cases. I'm extremely thankful to Dr. Kantilata Pai, Dr. Vidya Monappa, Dr. Sindhura Lakshmi, Dr. Swati Prabhu, and Dr. Nishchita for participating in this slide seminar. Also, I'm thankful to all the PGs who presented the cases from different institutes. And I'm greatly thankful to Dr. Aditya for organizing this session. Thank you.
you, Dr. Sushma ma'am. With that, I think we conclude, we come to the end of this slide seminar for the month of September, which was conducted by KMC Manipal. I thank all the faculty for the wonderful set of slides and all the PGs for their active participation. I want to highlight that the certificates for the same will be shared to their respective email IDs in a day or two. I thank all the faculty from KMC Manipal for discussing the cases, and they were all splendid cases. Thanks a lot for joining us. Thank you, Sushma ma'am, and thank you
Yeah,
all,
thank you.
Vidya ma'am, Kanti
Thank you,
ma'am,
Dr. Aditya.
Swati, Dr. Nishita for discussing the
Thank you,
cases.
sir.
Thank you.
Thank you all.
Thank you, sir.